Good evening. Welcome you all to this month's edition of Tamil Nadu ASC Chapter Monthly Meeting. Hopefully this is one session. Next session will be, we have one more before we go for midterm ISGTNC August. So we are back to the head office, and Dr. Prem Kumar, President, is not able to come here because of his personal reasons. So we'll start off with the postgraduate session. I request Dr. Santhi Sharmi, Dr. Sheshadri Venkatesh, Dr. Shanmuganathan and Dr. Joseph to chair the session and conduct the proceedings, please.
Good evening. I think we'll start right away. We have 3 cases and then a review of Indian literature. The first, unexpected cause of recurrent acute pancreatitis. Dr. Tarun Jaj, MGM.
Good evening. I'm going to present an interesting case of recurrent acute pancreatitis. So, clinical presentation, 39-year-old male from Dhaka with no apparent comorbid illness, had recurrent abdomen pain for the last 6 months. He had 2 admissions and he was diagnosed with acute pancreatitis and was managed conservatively and resolved. No past history of jaundice or ethanol intake, and he was referred to us for further management. He came to our OPD. He was asymptomatic at that period at time, and clinical examination was unremarkable. On routine blood investigations, CBC was normal. The only abnormality was alkaline phosphatase was mildly deranged, and the tumor markers were negative. CA99, CEA was negative, alpha beta protein was negative, amylase lipase was normal. CT abdomen done elsewhere in Dhaka showed segmental. CT abdomen done at Dhaka showed segmental intrahepatic biliary radical dilatation with a thickened wall at the porta hepatis. An MRCP also was done, showed an irregular, ill-defined, altered density on T2 weighted imaging in segment 5 and 6 with dilatation of the right anterior and posterior sectoral duct. So provisionally we had a diagnosis of recurrent acute pancreatitis with query parasitic cause. So we proceeded for an US. So EUS showed in imaging in the gastric station, showed an hyperechoic, ill-defined soft tissue lesion at the hilum. Yeah. You can see here, 1 second, I'll just play it again. You can switch out the lights, I'm not seeing it all. The lights. So you can see an hyperechoic lesion, a soft tissue lesion in the hilum. 1 second. Yeah, this. It looks like it's coming in the portal vein. Actually, it's like an overlapping image. So then we proceeded ahead with ERCP. So after selective CBD cannulation, the cholangiogram showed segmental dilatation of the right anterior and posterior sectoral duct and a very suspicious vague filling defect at the hilar region in the right hepatic duct. So then we proceeded with the sphincterotomy and balloon trawling. Following balloon trawling, there was significant amount of bleeding, which was unexpected. So we went ahead, because of the lesion in the right hepatic duct and hilar region, we went ahead with the cholangioscopy with gentle water irrigation and suction. We did a cholangioscopy, went right up to the hilum region. There was some amount of mucin noted at this stage. And then in the right hepatic duct, we could see like a papilliform lesion in the right hepatic duct. So then we went ahead with a spy bite biopsy of the lesion. Post-procedure, he developed cholangitis, which was managed with IV antibiotics with meropenem. And post-procedure, we did an MRCP, which showed ill-defined intraluminal T1 hypointense area in the right hepatic, right anterior sectoral and posterior sectoral duct with upstream intrahepatic biliary dilatation of the right lobe. The histopathology showed a mucinous papillary cytoarchitecture with low-grade dysplasia on hematoxin neosin staining, which was suggestive of intrapapillary neoplasm of the bile duct with low-grade intraepithelial neoplasia, gastric type. So after MDT with surgical and medical oncologists, it was decided to proceed for surgical resection. He underwent right hepatectomy with hepatic jejunostomy. Post-op period was uneventful and he was discharged. He was doing well in follow-up. So regarding IPNB, it's characterized by intraductal papillary growth with a fibrovascular core and can develop anywhere along the biliary tree. The tumor spreads superficially along the biliary tree, can be multifocal, and it has a high malignant potential. IPNB are rare and comprise 9 to 38% of all bile duct cancers. It predominantly occurs in the age group of 50 to 70 years with a slight male predominance. And it's more common in the Far East countries. The etiopathogenesis, it is known to have like risk factors of hepatolithiasis and liver fluke infections, like chronic inflammation due to bile stasis, either due to hepatolithiasis or biliary infection, resulting in biliary stem progenitor cells to undergo a series of genetic changes which progress from dysplasia to invasive carcinoma. So cholangiocy arises from two pathways. The most common is like biliary intraepithelial neoplasia progressing from low-grade to high-grade dysplasia to carcinoma in situ. The less common pathway is IPNB with low or intermediate grade intraepithelial neoplasia, which again progress to high-grade and carcinoma in situ. So there are 4 subtypes. The most common subtype in IPNB is pancreatobiliary, and that has the highest rate of invasive cancer. The second most common is intestinal, which also has an increased rate of dysplasia. In our patient, it was a gastric type, which has a pretty good prognosis. So it's the IPNB initially starts off as a micropapillary lesion with varying degrees of mucin production. And based on the progression, say suppose the patient, it progresses just only mucin production without any biliary obstruction, it presents as mucobilia. And in typical intrahepatic IPNB, if the tumor growth is intraductal predominantly with low amount of mucin production, it presents like our patient who had an intrahepatic mass with segmental dilatation. If there's a complete block with mucin production, it can present as a cystic IPNB. So these are various presentations of IPNB. And if there's a tumor extension to the extrahepatic, especially in the hilum, due to peribiliary glands, there's increased risk of lymph node metastasis and invasive cancer, and it has generally considered to be a poor prognosis in the extrahepatic, especially involving the hilum. So the clinical presentation, a small group of patients are asymptomatic. They can have vague right upper chondral pain or present with obstructed jaundice or recurrent cholangitis. So diagnosis, LFT can show elevated alkaline phosphatase or GGT. CA99 can be elevated in around 35% in benign form and elevated in 61% in the malignant form. Various presentations on CT are there. One is ductal ectasia with intraductal mass, or the mass will not be seen, just diffuse ductal ectasia. The third variety, you can have just an intraductal mass with segmental dilatation. And other varieties, it can present as a tumor-like cast predominantly in the left segment. The last variety, it can present as a stricture with proximal dilatation. On MRI, it's an hypointense mass on T1 weighted imaging and hyperintense mass in T2 weighted imaging. But the best diagnostic modality is cholangioscopy. The advantages are you can directly visualize the mass You can characterize its morphology and its extent, take biopsies, and in some cases where they are not fit for surgery, you can use ablative techniques like photodynamic therapy or radiofrequency ablation. So differential diagnosis of IPNB are mass-forming intrahepatic cholangiocarcinoma, recurrent pyogenic cholangitis with hepatolithiasis, biliary mucinous cystic neoplasm, and choledochal cyst. Treatment in intrahepatic IPNB, in our case, similarly, if it's just right side or left side, can go for liver resection, or if it's a multifocal papillomatosis, you'll have to go for liver transplant. In extrahepatic IPNB, pancreatiduodenectomy and cholecystectomy. Endoscopic treatment can be considered in surgically unfit patients who are not willing for surgery, can go for cholangioscopic guided photodynamic therapy or endoscopic radiofrequency ablation. This is just a case report of a similar case which is reported, a right hepatic IPNB, which was treated with photodynamic therapy as the patient was not willing for surgical modality. The advantage of photodynamic therapy, the PDT catheter can be used in the spyglass cholangioscope. With RFA probe, it's not feasible. So in that way, it's a different modality where through spyglass cholangioscopy, you check the extent of the lesion, and then you pass the RFA probe, and then you can go ahead with the RF ablation. To summarize, IPNB are a rare biliary cousins to pancreatic intraductal mucinous neoplasms. They are pre-malignant lesions and can occur anywhere in the biliary tree, and commonly they present as right upper quadrant pain, jaundice, and fever. Cholangioscopy is the best modality for diagnosis. IPNB presenting as a recurrent acute pancreatitis has not been reported. We assume that maybe the tumor could have sloughed off and gone and caused a pancreatitis, or sometimes if there's mucin secreting, that also can sometimes trigger a pancreatitis. So treatment is surgical resection, endoscopic treatment in surgically unfit patients. There are a few case reports. Thank you. That's what we assume that, yeah.
Sorry, explained already.
Yeah.
That's fine. He wasn't stented after the procedure?
Oh, stenting was done. I forgot to mention we had placed a stent, but still
That's
patient
what I
developed
thought.
cholangitis.
Right. Very interesting case. I think it's quite a rare scenario. You get it.
No, when he came in Dhaka, it was around 4,300 in that range, ma'am. It was a documented pancreatitis, ma'am, in Dhaka. Those imagingly I had mentioned, ma'am. Yes, ma'am. Dilatation at that stage.
Very, very interesting. And the main interest was the recurrent acute pancreatitis. So you always think something in the PD rather than in the isolated CBD. So you said, like you said, common channel or something might have, because when you were taking the biopsy, I remember how it fell off, and we were very inclined to just pluck it, because when he pulled it for the biopsy, it came, but then they stopped because they didn't have the histopathology. I think it was a beautiful demonstration of the advantages of spike cholangioscope, where you can go in and see what it is. It's amazing, that instrument which has come now. In pediatrics, when we get recurrent acute also, we try the same thing. We teach the PGs GOAT, genetic obstructive. The obstructive can be pancreatic, it can be CBD in us, because we have choledochal cyst. So whether this boy had, because he's young, whether he had a fusiform type of choledochal cyst with a common channel where we explain pancreatitis, and in that he developed this, we do not know. That is far-fetched, but I think we should think in those lines, because we do get them. We say A is for autoimmune, T is for the toxin or the drugs. The genetic we always keep in mind, and we do have a common bile duct alone ice form with pancreatitis, and that is only the choledochal cyst, because we feel that in the anatomical, in the development itself has developed. So I think the fusiform, the histopathology came as interpapillary. He showed.
I showed, ma'am.
Very nice. I think he was so.
I think GOAT is the trending word now. So that's there in pediatrics also.
So they don't forget, because
for all that. Yeah, it's true.
Genetic, obstructive, autoimmune, and toxic.
Nice point.
So it has a mucinous papillary architecture with low-grade dysplasia.
Papillary.
Yeah, you can see. Yeah, mucin. Yeah. No, sir. We have actually the surgical specimens have been sent, sir. It's done last week, so. Yes, sir. On histopathology, they are told it's gastric. Yes, sir.
So, unless you do a immunohistochemistry
Okay, sir.
for CK7, how can you say it is not a pancreatic or biliary? That is one. Second one is when you
The
did a-
pathologists had given said it's gastric type.
when you did a cholangioscopy, did you go into the left ductal system fully?
Left duct, we didn't. I mean, we just went to the right duct and deep, sir. Beyond this lesion also.
Is it,
actually.
I mean, is it technically possible to go to the left ductal system and see?
Left duct also you can do.
Because
Can.
it's better to see because we should not miss a multifocal.
Multifocal. Yes, sir.
Moving to the next case, post-DVR DILI acute liver failure from medical GE department, SRM Global Hospital by Dr. Harshvardhan.
Good morning, everyone. I'm Harsha, General Medicine PG, and here to present an amiodarone-induced hepatotoxicity. So here we have a 65-year-old gentleman who is a known case of rheumatic heart disease with valvular complications of mitral regurgitation and aortic regurgitation, presented with shortness of breath of grading NYHA class 3 for last few weeks. He was admitted with the plan of double valve replacement and had an unremarkable pre-anesthetic evaluation. And had undergone a procedure which was uneventful. 24 hours post-procedure, the patient complained of palpitations which was confirmed to be paroxysmal AF with fast ventricular rate on ECG and was started on IV amiodarone infusion with bolus of 300 mg over 1 hour followed by infusion of 1300 mg over next 72 hours to attempt for pharmacological cardioversion. On day 4 after starting IV amiodarone infusion, it was noticed that the urine in the urobac was high colored. So subsequently LFT was done and medical gastroenterology opinion was taken as it turned out to be abnormal. The LFT done on day 5 after starting amiodarone was suggestive of hyperbilirubinemia with total bilirubin of 4.1 and mild elevation of liver enzymes with INR of 2.5 due to warfarin which was started post-OT. Patient was started on an NAC IV infusion in view of drug-induced liver injury at 100 mg per kg over 24 hours which was eventually continued for 72 hours. Anticoagulation cover was shifted to IV heparin, 2000 units every 8 hours, and warfarin was tapered. On day 6, patient developed slurred speech and had flaps on examination. ABG was done, which showed lactate of 0.9, metabolic alkalosis, probably secondary to volume contraction, as the patient is on diuretics. Patient was explained about the need for plasma exchange but could not start until the day 8 due to logistic reasons. By that time, the patient had already progressed to hepatic encephalopathy grade 2 with worsening bilirubin of 36.8 and INR of 2.0 despite stopping warfarin. Here is the charting of the LFTs which were done serially. On pre-OT, LFT was unremarkable. On day 4 after starting amiodarone, bilirubin was 4.1. Of direct 0.3 and SGOT were mildly elevated and remaining all were unremarkable. And day 5 showing marked hyperbilirubinemia of 27.1 and SGOT of 2300 and 1400. NAC infusion was started on day 5, post which the bilirubin failed to drop and increased to 36.8 on day 8, after which Plex was started and continued for 5 cycles. And the serial bilirubin values were 33.9 to 16.4 after 5th cycle of Plex. The patient was alongside started on LOLA and patient sensorium improved after first cycle of Plex and progressively LFT was improved over the next 5 cycles over the 5 days. Patient was discharged on day 16 followed up closely over the next 3 weeks during which LFT came back to with normal limits. So in this case, the points suggestive of amiodarone-induced liver injury were over the procedure and throughout the stay, there was no recording of hypotension, ruling out ischemic hepatitis. Relative time frame of liver injury immediately after starting amiodarone is more suggestive of liver injury due to amiodarone. No other hepatotoxic or native medication intake as per history in the hospital, and notable vital markers were negative. So coming to amiodarone, it is an antiarrhythmic agent belonging to class 3, in which it's given in two ways, both IV and oral form, and its half-life is comparatively long, which is of 20 to 100 days. It mainly acts on myocardium, predominantly blocking potassium channels. Amiodarone used in the treatment of refractory and ventricular arrhythmias as means of rhythm control for prevention of sudden death. So this is the structure, and bioavailability of oral is 20 to 55% with protein binding of 96%, and excretion is primarily through bile. So common side effects of amiodarone, as we all know, include hypothyroidism, hyperthyroidism, corneal microdeposits, bradycardia, AV block, pulmonary fibrosis, which is on long term, and mild transient elevation of AST liver enzymes is seen, which is like subclinical and often self-limiting. Relatively rare side effects of amiodarone include steel blue discoloration, photosensitivity, hepatitis, and very rarely cirrhosis, hyperlipidemia, and transfusion site reactions. So amiodarone-induced hypotoxicity is mainly characterized by histological steatosis, inflammation, fibrosis, and phospholipidosis. Drug-induced phospholipidosis is characterized by intracellular accumulation of phospholipids with lamellar bodies, most likely from impaired phospholipid metabolism of the lysosome. Organs affected by phospholipidosis exhibit inflammatory reactions and histopathological change. Phospholipidosis can be present without evidence of cirrhosis and should be considered more as an indication of drug ingestion rather than hepatotoxicity. The hepatotoxicity due to amiodarone is mainly reported as both acute and chronic, acute being mostly due to IV and chronic being mostly due to oral. The most cases of acute and chronic liver failure are related to amiodarone associated chronic steatohepatitis, and microabscesses have also been reported in few cases. So acute toxicity is rapid, and most cases have occurred around 24 to 48 hours after initiation of IV administration. There are mainly four mechanisms on which the cases were reported. Mainly the first one is direct toxicity of the vehicle. It's mainly the amiodarone is not it's not a stable compound. It's transported in dilutants like polysorbate 80 and benzyl alcohol, which will stabilize and make it soluble in saline. Second one is idiosyncratic reaction. Third is hypersensitivity and free radical formation. So risk factors for acute toxicity include as we already told, polysorbate 80 diluent in specific IV formulation, hepatic congestion, and history of alcohol use disorders. Chronic toxicity is delayed. Most cases occur after at least a year of oral therapy. Mechanism not clearly established and may be related to direct damage through lipid layers and lysosomal damage and mitochondrial dysfunction. Risk factors for chronic toxicity usually is seen in cases with cumulative dose of more than 400 mg per day. So this is the normal amiodarone is available as it is. We can see this polysorbate as stabilizing agent and also benzyl alcohol. Some forms come without polysorbate 80 and with only benzyl alcohol. As we said, amiodarone is not stable in aqueous solution and therefore must be dissolved in solvent such as mixture of polysorbate 80 and small amount of benzyl alcohol. These molecules exert hemodynamic effects, and polysorbate 80 has a potent vasodilatory effect and negative inotropic effects. But as in this case, we didn't observe any hypotension, so that might not be the cause. Benzyl alcohol is an aromatic alcohol used as a bacteriostatic and solvent, has been responsible for respiratory insufficiency, seizures, and hypotension. Furthermore, polysorbate 80 has been implicated in E. Ferrol syndrome, which is characterized by hepatosplenomegaly, cholestatic jaundice, renal failure, and thrombocytopenia. So the clinical manifestations mainly include nausea, vomiting, jaundice, and often go unnoticed unless until its severe hepatotoxicity is seen. So lab investigations, complete liver function test may reveal serial rise in AST, ALT, hyperbilirubinemia, and few cases have reported there is liver showed hyperintensity on ultrasound and CT abdomen. Liver biopsy, if done, may show the following findings: centrilobular necrosis, nutmeg pattern of hepatocytes, apoptotic hepatocytes, and canalicular cholestasis. Management mainly includes discontinuation of IV amiodarone, anti-inflammatory drugs, replenishing glutathione, reintroduction of oral amiodarone is tried in few reported cases without any evidence of liver injury subsequently. These are the few cases are already reported which are having amiodarone-induced acute hepatitis, and also were reported with polysorbate ATUs. Thank you.
First of all, I appreciate being a medicine PG presenting in a gastro convention. It's really good. All the best.
Since it's a post-operative case, you have to think in other like anesthetic agents can also cause hepatitis, acute liver failure. So you should know what are the list apart from amiodarone. I agree, but what are the drugs which used for during anesthesia? That's also important. Some of the sevoflurane hepatitis that can cause acute liver failure. You need to check that also.
The audience, anyone?
Double valve replacement.
Double valve replacement. Rajesh.
We were on verge of losing the patient. He was rapidly progressing. On one side, financial constraints. On one side, there was some financial constraint, and we had to delay the treatment until 3-4 days after he developed hepatotoxicity. But once we started Plex, the sensorium improved very rapidly, and also the jaundice progressively decreased. But after 5 cycles, the bilirubin was around 14, and after 10 days, it has come down to less than 4. And patient was discharged, and it was a very good outcome with Plex. 3 days, 72 hours.
3 days he received, and then jaundice came on which day?
5th day.
Hypersensitivity reducing critic.
No, 2,300 on day 5.
That is more like toxin related.
Yeah, he received quite a high dose, I think 1,600 milligrams over 72 hours.
That one looks like ischemic, no? That 1,400.
PT and OT are elevated, so it's more mitochondrial and cytoplasmic. Initially you might, but I think Plex is definitely, it's good, you must have done a lot of talking to them and pushed it.
Yes,
That
yes.
is the thing.
Correct,
It's
correct.
not easy. Refusing and then saying yes and to make the patient alive, I think that is very, very good. So finally, what do we say? It is due to the polysorbate. What is the lesson?
Yeah, that's what the literature says. As far as IV amiodarone is concerned, it's more than the amiodarone. It is the vehicle, that is the polysorbate, which exerts acute liver failure.
Excretion rates is on day 5, no? The problem has occurred on day 5. It's day 5 that the
Yes.
bilirubin has increased. So what's the excretion rate of an IV amiodarone?
A very, very, very long bioavailable.
No, that is
Highly protein.
oral is stimulated with IV.
IV.
What's the rate of excretion? So day 5 would be, no, day 5th day would be the bilirubin is day 5. So something has happened on day 5.
No, he was on continuous amiodarone infusion. From after surgery, this patient developed atrial fibrillation. He was on continuous infusion for 3-4 days.
Between day 4 and day 5, something has happened.
Something has happened between day 4 and day 5. We cannot shoot up from 4.1 with a normal AST-ALT on day 5.
But there was no recorded hypotension or he was not an inotrope during the entire
So
course.
basically, what I want to know is what's the excretion, no? You're giving IV, what is the excretion rate and is it cumulative? Is it finally a cumulative accumulation causing that day 5 problem?
Yeah, probably, ma'am, probably. I'm not very sure.
I just want to, you presented in the discussion, but I just want to ask you this question. A patient taking amiodarone for a long time, if you do a CT scan, what will you appreciate?
CT scan of
Abdomen. What will you appreciate in the liver? You told actually.
hyperintensity.
Yeah. So whenever you see more Hounsfield units in plain CT, one possibility is the patient is taking amiodarone. Other thing is like hemochromatosis, hemosiderosis, all those things.
Thank you, Doctor. That was a wonderful presentation. Now we shall move on to the next case. Let there be no hurry for endoscopy in corrosive injuries. Presented by Dr. Akhil Chowdhury, Department of Surgical GE, SRMC.
Case 1 is a 23-year-old male who swallowed a bathroom cleaning acid of suicidal intention. Admitted under general medicine in view of pain abdomen, change in voice, vomiting and restless. Admission findings were that pulse was 100 beats per minute, BP of on the lower side of 100/70, but saturation was maintained. Chest and abdomen were normal with mild epigastric tenderness. Chest X-ray and abdominal X-ray was normal. So the patient was proceeded for endoscopy, wherein you can see the findings of extensive mucosal necrosis noted in the esophagus along with the stomach. So post-endoscopy, it was noted that the patient had deteriorated very fast with a heart rate of 140, respiratory rate of 40 minutes. So he was intubated and ventilated, wherein we have repeated the investigations. It was suggestive of elevated total counts, deranged coagulation profile, elevated LFT, enzymes, sorry, not enzymes, total bilirubin and potassium of 6.2. So the patient was in ICU, so SG consult was sought, wherein we asked for a bedside X-ray suggestive of massive air under diaphragm, suggestive of perforation. So the patient was proceeded to emergency laparotomy, wherein we noted a large amount of blood and bile stain fluid, large amount of free gas, total stomach was completely necrosed. So this is the resected specimen where we can see that the stomach has lost its normal anatomical structure and it's completely necrosed. So we couldn't maintain the actual anatomical. Along with that, the esophagus was also necrosed. So the esophagectomy and cotal gastrectomy was done. And this patient had a cervical esophagostomy. Along with that, feeding jejunostomy was done. So the post-op follow-up of this patient, patient had a stormy post-operative course and lying in the hospital for almost 1.5 months, wherein he recovered well, and we planned for to do a reconstruction in him, wherein he had come around 3 months later, suggestive of extensive oral fibrosis in the tongue. So the patient never came for follow-up for almost 1 to 2 years, but however later it couldn't be planned for further management because we lost to follow-up. Next is a case 2, is a 56-year-old female who had a alleged history of harpic conception or a tooth brought to the ER within 1 hour of abdominal pain, epigastric region, dull aching and burning sensation. There was 2 episodes of induced vomiting at home. Patient is a known case of clinical depression on medication with previous multiple suicide attempts. On examination, patient pulse was 120 beats per minute with hypotension. Room air saturation was 92% with acid burn.
Sorry for the delay. There was acid burns noted on the face and the arms, and the tongue, buccal mucosa and pharyngeal region was erythematous and edematous. Per abdomen was soft with mild tender as the epigastric region with no guarding or rigidity and no obliteration of liver dullness. Respiratory system, bilateral air entry was reduced. However, no crypts or surgical emphysema was noted.
Patient did not respond to initial resuscitation in the ER and was shifted to ICU for further management over there, wherein the ABG showed a severe metabolic acidosis with the lactate levels of 8.7. So in view of the above findings, patient was intubated and started on low dose inotropes. In suspicion of perforation, she underwent a CECT abdomen and chest, where she showed no signs of perforation. So the patient further developed AKI, so needing for hemodialysis for the same. These were the admission laboratory values, where she is showing signs of total counts of 26,000, creat of 2.8, burn of 66, and the enzymes were in the normal range, only SGOT was deranged. So MG consult was obtained and the bedside endoscopy was done, wherein it was reported as Zargar grade 3B. So SG consult was sought in view of continuing deterioration, endoscopy findings and requirement of inotropes, and CT not showing any evidence of perforation. So we did a rapid assessment on the bedside in the form of ESG guided aspiration of the fluid, wherein it was hemorrhagic. So we shifted the patient to the theater for emergency laparotomy, wherein we have noticed a very extensive necrosis of the stomach, completely deranged stomach. So, and along with that, we have seen that the necrosis has been seen in the patchy areas of the antrum, wherein we suspected that the acid has come out and damaged the part of DJ flexure along with colon. So finally, the patient underwent a total gastrectomy along with left hemicolectomy, and the area of the patchy necrosis in the DJ flexure was also repaired. This is the sutured proximal jejunal necrosis, and this is the resected version, wherein right side is showing a left hemicolectomy, and this is the resected stomach. So patient finally landed up with end transverse colostomy, feeding jejunostomy and tube duodeноstomy. However, because of extensive necrosis and the patient's STOMY postoperative case, the patient succumbed to her injuries 2 days post-op. Case 3 is a 22-year-old male who had alleged history of harpic consumption query around 50 ml at night, 11 o'clock, with history of trauma to head, query fall or self-infected. History of vomiting 2 episodes, non-projectile and non-bilious. Patient was noticed by attenders and was obeying commands at that time. He was wheeled into ER around 6 a.m. with suggestive of a patient was drowsy, arousable, only to painful stimulus, and intubated in view of low GCS. So he was intubated in the ER. At that time, his vitals were remarkably stable, but however, he was on ventilator. There was a laceration on the forehead and respiratory bilateral air entry was present. Abdomen was soft, non-distended. Because the patient was in delirium, we couldn't evaluate whether he has tenderness or not. Labs and admission suggestive of severe metabolic acidosis with elevated total count and elevated creatinine phosphokinase. So this was a plain CT which was done in casualty, because patient had history of trauma also, where we can see that there is no pleural effusion, and the stomach was massively distended, and the proximal loops of small bowel were distended, but no pneumoperitoneum is noted. So patient was shifted to ICU. Worsening of vitals were noted over the next 4 hours. Inotropes were started. Both surgical, the gastroenterology department was involved. So when we have seen the patient had a pulse of 135, BP on inotropes. Per abdomen was mild distension with guarding noted in the epigastric region. The suggestion was to do a CCT from surgical gastro team, and the medical gastro team has advised for bedside endoscopy. This was the values post 4 hours when we have seen the patient with the total counts of 21,000 and deranged coagulation profile. Lactates were elevated and creat was also started to elevate, and urine myoglobinuria was present. This is the CT Gare initial image where massively distended stomach is seen. So this is the arterial and venous phase of the patient, CT thorax and abdomen. We can see that there is a signs of already left side pleural effusion has started, along with massively distended stomach with the loss of stomach wall and rugal folds. No enhancement is seen in arterial or venous phase. And there was a submucosal edema noted in the early parts of duodenum and jejunum. So they have given the report as suggestive of gastric necrosis. So this is the diagnostic laparoscopy where patient proceeded. We could see that the stomach was totally necrosed with a lot of muck and altered fluid in the abdomen, more of blood and bile. So we rapidly converted the case to open surgery. This is completely necrosed stomach, which you can see that it has lost its contour. So this patient has survived, was kept in follow-up, and now is planned for reconstruction surgery. Even he had also a stormy post-operative course. This is a case of a 29-year-old male with Harpic consumption around 8:30 p.m., quantity unknown, presented to ER around 1 a.m. with complaints of epigastric pain and blood vomiting. Pulse rate was around 140, BP was 110/80, saturation was on 92% with 15 liters oxygen. Respiratory system was normal. However, per abdomen, we have noticed a mild epigastric tenderness present, but no guarding or rigidity or no obliteration of liver dullness. Patient ABG was suggestive of severe acidosis, hence he was intubated in ER and shifted to ICU for further resuscitation. Here, we have noted that again the patient had similar findings of severe metabolic acidosis with elevated total counts and deranged total bilirubin, direct bilirubin. Labs after resuscitation showed partial response, however total counts were diminished, but platelet levels were dropping. So this patient CT, here's the CT where we can see this was the early CT done within 12 hours. There was no pleural effusion. However, there was a diffuse thickening of the stomach noted, along with submucosal edema, hypoenhancement of the mucosa and submucosa is seen, but again no free air under the diaphragm or pneumoperitoneum. Minimal ascites was seen. So with these symptoms, we have the patient was medical gastro opinion was sought and advised endoscopy. However, we took the patient for diagnostic laparoscopy, wherein we can see that there is necrosis of the stomach. You can see the yellow patch over near the body and the antrum that is suggestive of transmural necrosis, along with the very hyperemic stomach. This is the diagnostic laparoscopy image. So we can see that that was extending. That is a gallbladder. So this also patient was converted to surgery, open surgery, wherein we have noted that there is complete transmural necrosis of the stomach. The stomach was totally non-viable, and the proximal part of OG junction was also involved. So this patient underwent total gastrectomy with feeding jejunostomy. This is the feeding jejunostomy, and this is a cervical esophagostomy. Patient survived the post-operative course and is being planned for reconstructive coloplasty at present. So the summary of the 4 cases is that there were 4 cases who had a massive necrosis of stomach, in which 2 cases endoscopies were done, 1 case endoscopy was advised, and the last case endoscopy was not advised yet. So the idea behind this presentation was, is early endoscopy within 24 hours a must in cases with severe injury? Does clinical presentation of patient dictate for early endoscopy? Should endoscopy wait for response of resuscitation? Whenever a caustic injury is wheeled into the ER or to the hospital, it has already 4-5 parts of the treatment, where there is initial resuscitation, evaluation of grade of injury, treatment of early complications, nutrition, stricture management. The presentation mainly focuses on the second part, that is evaluation of grade of injury. The overall common idea behind the evaluation of grade of injury is whether it's high grade or low grade, where in high grade we taking them directly for surgery, and low grade is managed conservatively. So now further to classify them, how to classify them regarding high grade or low grade, and the timing, that is what the question of debate is. So Zagar was done from PGH Chandigarh, has done extensive study in the 1990s to classify them. So here we are talking about more of 3B. 3A and 3B is the patients which we are in discussion. The biochemical parameters which are suggestive of transmural necrosis are metabolic acidosis with elevated lactate levels, leukocytosis, thrombocytopenia, and high CRP level, and deranged liver function test. This is the established criteria have been debated upon and been published in the literature. World Journal of Gastrointestinal Endoscopy in the year 2018 have suggested the contraindications to endoscopy in the form of suspicion of GI perforation, necrosis of oral cavity, and compromised airway. And in NEGM, there was a review article which was published in the year 2020, where they are suggesting that if the patient is too ill or imminently unstable to undergo endoscopy, CCT is an acceptable diagnostic alternative. Again, there are 2 groups of thoughts who are telling that first CT should be done or first endoscopy should be done. But in patients whom we are really unstable and lab parameters are not good, getting a CCT done is a better alternative. This is a Lancet study which was published in 2017, where the group is totally against endoscopy and they want CT to be the initial investigation for patient with caustic injuries, wherein they suggested grade 2 onwards to get a non-operative management and endoscopy. So how do you grade this CT, grade 1, grade 2, grade 3? They suggested that grade 1 is normal appearance, wherein grade 2 you can see that there is a soft tissue edema with increased wall enhancement, and grade 3 is complete transmural necrosis with absent wall enhancement. And this is an Indian study published by JIPMER group, where this is a protocol which is being followed in JIPMER, where acute corrosive ingestion comes, they evaluate the patient clinically to see whether there is peritonitis or mediastinitis or hemodynamic instability. If any of these features are present, the patient is immediately wheeled into surgery. But if there is not there, but clinical suspicion is there, they proceed to get a CECT done. When CECT, if it is grade 1, there is no endoscopic discharge. Again, grade 2, it's non-operative management and endoscopy, and it is emergent surgery. So the conclusion of this case series is that special attention to patient's clinical status is essential for evaluating the grade of injury. Endoscopy in a hemodynamically unstable patient is unfruitful and can cause more harm than aid in the management. CECT's imaging is best alternative in very sick patients. When patient is stable, endoscopy is the standard to grade injuries within 24 to 48 hours. Thank you. Ma'am, it is around 35% sulfuric acid, ma'am. Yes, ma'am. 35%, ma'am. But again, they have diluted. There are a lot of law reforms coming up by the government because of this. But however, the standard one which we are getting in the market right now, it's at 35%, ma'am.
The districts, no?
Yes,
and
ma'am.
the police also come, AR, for litigation purposes, for that thing, they want to assess the severity. So what will we tell them? They may have a scope, but CT they may have to send somewhere else.
Ma'am, we want to
If
suggest...
it is abdominal distension and all that, we will not do. But suppose, they just tell us, you're not sure, it may not be 3, maybe 2, 3.
That's fine, ma'am. We are suggesting that in hemodynamically stable patient, endoscopy can be done, wherein we can grade very early.
Okay.
But if the patient is unstable or the lab parameters are not on the favorable side, or the patient is complaining of massive pain and epigastric, then we can wait. So later hours, after 12 hours or 18 hours post-consumption, maybe the stomach can show the necrosis. Ongoing necrosis will be well pronounced.
We always used to say, do it with the surgeon behind you.
Because in
so
one
you're
case...
the surgeon, so no?
One case they had patient had a lot of pain and all, wherein endoscopy was done, then the acid has come out and damaged the colon
Yes,
and
yes. That we have to
jejunum.
be careful. I think
Yes.
Restraint and doing it is the most important. I think the CT was very good, doctor. That I think is
one point is sometimes endoscopy overestimates the jargon.
Yes, sir.
CT scan clearly after third day CT sometimes it shows the real state of affairs. That's
Yes,
a CT score. So CT scan really scores a point. But for me endoscopy is 5 minutes affair. So that will
Yes,
be
sir.
easier for me. That's it. That's it.
Yes, ma'am. IV contrast, we'll see enhancement can be seen, ma'am, in IV contrast.
I agree with you that the patient's condition should be fit enough for endoscopy. But I won't blame endoscopy also,
No,
because
sir.
when you do an endoscopy, if you see something black, you stop it. You don't proceed further, because there is a lot of chances there may be necrosis in the stomach
Yes,
also.
sir.
If you proceed, then you can make a catastrophe.
I think Harpic is not sulfuric acid. Hydrochloric acid. Harpic is hydrochloric acid. Okay.
I'm sorry, sir. I got
So
confused.
I don't know the concentration. I think it's 10%, not 35. It's just 10%. So it's acid injury only. The idea of presenting this case is number one, to show how the gastric necrosis occurs from outside, because you guys have been seeing from inside only. So gastric necrosis, how it's seen from outside, is shown, madam. And second thing is, even if you do endoscopy, I am of the opinion that there is no need to do it in a very hurried manner within 24 hours. We are not going to achieve anything. Just you can do it maybe at the end of 48 hours, where if the patient is going to have severe injury, that itself will manifest. Patient will have tachycardia. So there is no need to hurry with an endoscopy within 12 hours, or because the problem is these corrosive injuries gets labeled as corrosive poisoning. And because of that, patient gets admitted under general medicine. And then it goes to ICU. From the ICU, gets referred to medical gastro. And medical gastro resident goes there and advises endoscopy. The point is, this is for residents, when you go and see the patient in the first 24 hours or 12 hours, examine the patient and find out, is there any contraindications for doing endoscopy rather than doing an endoscopy. That's what I want to say.
And also tell the ER not to place an NG tube. I had a child in pediatric, very well they placed the tube and they said, Madam, I placed the tube. And I was not even sure. And they took an X-ray and they said it's there. Finally, it had perforated the stomach and was lying in the left iliac fossa, gutter. So, like he said, you don't know, abdomen was soft. Like all the features which you think of necrosis, not there. Yes. So I think very good eye opener, not to do endoscopy, not to place NG tube also. The NG tube also will go through.
The next presentation is a review of literature of the gallstones. But before that, I have a small quiz. So 5-minute quiz, and then we'll have the review of literature for the gallstones. So good evening. So there's something which I saw. It's supposed to be a pendant which says no gallbladder club. So all the patients who have undergone, we're going to talk about gallstones, all patients have undergone a cholecystectomy. So I thought I should put this pendant. So Pittashmari is a Sanskrit word for gallstones, something which I came to see. So which is the first, who gave the first documented report of gallstone? First documented report of gallstone. I think there's prize for every answer. MCQ. I can give you some clues. Okay. Mask of Zorro. Mask of Zorro. Actor. Antonio Banderas. Okay. One answer is Antonio. One part of it is Antonio. So, Antonio Beniveni. It's in 1420. This is a person who was first given the documented evidence of a report of gallstone in the report. So this will go off to the next question. I think next two questions are surgical questions. I think surgeons should be able to answer. Surgical PGs are here. I think one is there for sure. Two. Okay, before going to that, in our Sushruta Samhitas also, we have evidence of mention of gallstones. No? He's explained about how pitta is important and how gallstones are formed. So I think we should be proud about our history also. So now we do cholecystostomy when we are not able to, as a bridge, but that was the first surgical intervention which was done for gallstones. So we'll go to the next question. Who did first open cholecystectomy? Well, let them answer first. If they don't answer, it will come to you. Anyway, even medical PGs can answer. I mean, can take a chance. One of the word is this month. One clue. August is still there. Okay, sir. You want to say? Correct. Is Carl Johann August Langenberg. So I think Dr. Shankar can take this.
No, Carl Langenberg told in gallbladder stones, gallbladder is removed not because it contained a stone, but it forms a stone. That's why because a lot of patients ask, sir, kalla mattu edukka mudiyuma?
Kalla mattu. Even now they ask me, sir.
So for that, Langenberg has answered.
So this he did in 1882. And so that comes to the next question. Who did the first laparoscopic cholecystectomy? Again, someone else has to answer. Surgeons? No. Okay. It's Dr. Eric Muhay. I'm correct, no, sir? Okay.
Actually, it's correct only, but there are a lot of controversies in that area.
Okay.
Because laparoscopic cholecystectomy is described as it is born in secrecy and viewed with skepticism. Because there is a lot of confusion whether it's a French who did the first lap chole or a German.
German. He's actually supposed to be German. I think both are Germans.
Eric Muhe, Perisat, all these things are, they are fighting for the hat.
Who did first laparoscopic cholecystectomy in India? I think this they should answer. Fantastic. So one answer. I think he gets the answer. Professor Udwadia, it was in May 1990. I think the other one was 1985. You can take this. So we'll go to the next one. So identify this. This is open. I'll give a clue now. Okay. Audio is there. Okay. That's the clue. So you can identify what this is now. Anybody? Take wild guesses now, I think. Should be. Any wild guesses? I think PGs can answer. You should mix this and the video. No. Okay, these are gallstones from cow and bull. Gallstone extracted from cow and bull. So anybody answered that? No one. Okay. So why is that? I just happened to get through, no? So it has been found that this cattle gallstones are used in traditional medicine for sore throat, heart diseases, traditional Chinese medicine. I don't know, they use all sort of things. They use it for lung cancer, heart diseases. In fact, during COVID-19 epidemic, they had had a concoction which is said that peaceful palace bovine pill. I don't know how it's peaceful and palace. It contained cow gallstones, buffalo horn, jasmine and pearl. And they had actually, it was recommended by Chinese National Health Commission and was given to those patients. And God save them. It is also being sold for up to $50,000 per kg for so many purposes. So I think surgeons can have a good. So I don't know what they use for. Probably aphrodisiac. That's why it's so costly. Sir? Veterinary surgeons. Okay. So I think that's it. I don't know. Suddenly Aparna became Sendil Kumar today. So it's Aparna or Sendil Kumar? Sendil Kumar. Okay. Sunil Kumar.
Sorry. Thank you.
So serious business.
Next will be the review of Indian literature. Gallstone speaker is Dr. Sunil Kumar from the Department of Medical Gastroenterology, MMC.
Good evening, respected professors and dear colleagues. I'm Dr. Sunil, postgraduate from Institute of Medical Gastroenterology, MMC, guided by Dr. Shanti ma'am, AP of IMG, MMC. So I'll be doing today this month's review of Indian literature. Topic will be gallstones. So I've tried to clump the articles based on a methodological way, in a chronological way as much as possible. I'll be discussing the headings, namely definition, the demographic factors, pathophysiology, clinical presentation, diagnostic modalities, complications, prevention summary, and the references at the end. So gallstones is one disease where the etiopathogenesis is not fully understood yet. So defining it is itself a tedious process. So this one particular article right from the middle of India, from Nagpur by NPK Salve Institute, tries to define cholelithiasis as hardened deposits within the fluid of the gallbladder, secondary to imbalance between bilirubin, cholesterol, bile acids, phospholipids, and water and electrolytes as well. So it is a chronic recurrent hepatobiliary disease. Gallbladder as an organ is at a disadvantage because it is the thinnest part of the GIT. It has a small interrupted muscular layer and it has to empty its contents against gravity and has a lot of contact time because it is a pear-shaped organ as well. And owing to the anatomy of the cystic artery, it has a poor perfusion as well. So why it is important? It plays an important role in digestion. It is an outpushing of GI tract and it is prone to dysfunction and diseases, namely the stones, cancer, polyp, and dysmotility. So describing the prevalence of cholelithiasis across the Indian population, this one huge study is a population-based study. done by the Department of Surgical Oncology, Lilavati Hospitals, and also one big contributor was Indira Gandhi Hospitals in Bihar. What they did smartly was they took this 60 villages across the banks of the river Ganga. So the 60 villages which came along the banks of the river Ganga was housed to around 13,000 families, which hold around 22,000 individuals. So people of the age group above 30 were taken, and the symptomatic people were subjected to ultrasound. So this belt extending from the Himalayas up to the Calcutta is also called as the Stone Belt of India. So the prevalence what they found was in symptomatic individuals it was around 7%, and it rose from 4, 5 and 7 from Patna, Varanasi, and the last one being the Vishalachi village, which is owed to a huge reason of it is owed to the excess metallic intoxication in these rivers. So these people relied purely on these river beds and lakes coming from the big Ganges river for their own livelihood, drinking, washing and everything. So in this population, then this water, nickel, chromium, cadmium, all these three elements was found to be a higher concentration as well. And the other factors which owed to this prevalence was increasing age, and not only fat 40 fertile women were prone to cholelithiasis, malnourished females of multiparous pregnancy were also involved in cholelithiasis. And a lot of it was attributed to the toxic environment, secondary to the intoxication of the rivers, and they consumed excess amount of chickpeas, meaning low calorie, low protein diet all 3 times a day. So going to the next topic, which is the risk factors attributing to the gallstone formation in Indian population. The same study tries to define the demographic factors, namely sex distribution. Most of the studies, more than 95% of the studies, be it Eastern or Western, shows that there is a slight preponderance in the female sex as well. And the age group commonly described as 31 to 40 and 41 to 50. And let us go to a remote state of India, which is southern Odisha, and look at the prevalence over there. So in remote areas, the demographic data also shows that the age group defined maximum frequency was 41 to 50. And the diet maximum was mixed diet, which contained an excess of red meat. And the first clinical presentation of the demographic factors was always biliary colic. Until then, they were considering it as dyspepsia, and people used to self-medicate. So in an Indian population, in a southern Indian population, I think this study was done as much in Tamil Nadu. So the diet in North India and South India are very much different. So what they found was gallstones had a positive association with the body mass index. There are 2 factors which did not change across any of the studies which I went through. One was increasing age and increasing BMI. This always contributed to a increased preponderance to a gallstones. And southern people have this habit of adding tamarind to everything, starting from the rasam to the other curries also. And because of westernization of our rural population and Indian population as well, excess fast food items such as fried food and oil more than 300 ml contributed to the gallstone formation. And things which are protective or rather negative association with cholelithiasis were sugar intake more than 3 times a week. By this I mean people who consumed low calorie, low protein diet were at a higher chance of developing cholelithiasis compared to people who had a much better balanced diet. And good news to caffeine lovers, people who took more than 2 cups of coffee per week had a negative association, and high fruits and vegetables were also preventive. The same demographic data, we're going slightly deeper. Now that we've established it is more common in females, we're going to the rural population where they conducted a few more demographic factors among young females. So rural population, they took into account all these factors. So it was found that the prevalence was higher in people who were married at a younger age, multiparous women, lower socioeconomic status. And naturally, rural population, younger women, they were unemployed also, which added to the psychosocial stress which they placed. And because of urbanization and internet penetration, fast food has also reached the rural population as well. And what this study implicated in those patients, they had a high triglyceride, low HDL and a higher SBP count, contributing to the gallstones as well as high risk of other cardiovascular diseases as well. So one interesting fact was the total cholesterol and increased LDL did not contribute to gallstone formation. Rather, a high triglyceride and a low HDL contributed to gallstone formation. So summarizing the demographic risk factors which I discussed, one thing which did not change in all the studies was obesity and age. Pregnancy, we know, high estrogen, high progesterone state. The same for OCPs, hyperinsulinemia is the insulin resistance. And factors owing to GB stasis was low protein diet, high refined sugar, high saturated fats, and taking a high fatty meal and fasting post that. So even if you are practicing intermittent fasting, it is better to take a balanced meal and then fast. If you take a high cholesterol meal, naturally the cholesterol will reach your intestine and will obviously reach the liver for metabolism. And then you go on a fast for around 12 hours. So there is no GB motility which is going to happen. Supersaturation of bile happens and cholelithiasis occurs. And intestinal factors coupled with that, if your fiber intake is also low, all the more chances of developing a gallstones. One more age-old study, one done by Usha Datta ma'am and Shah, which showed that fatty meal reduced the GBEF to 20% and high protein meal made it to normal of 70%. So this plays an important role. As for practical purposes, we take the GBEF as 40. So higher than that, we treat them symptomatically. And how does obesity contribute to cholelithiasis? 85% develop dysmotility, and eventually they go into dyslipidemia 40%, and 3% of them have a prevalent gallstone formation. And people who had lower trace elements of vitamin D and C had higher risk of gallstones as well. Moving to the next topic, which is the composition of gallstones itself. There are three types, which we all know: mixed, cholesterol, and pigment stones. So this is a study in North Karnataka, which is very much part of South India. So done at KIMS Hubli, they analyzed these stones based on colorimetric and titration methods. So as we can see, the most common stones in Western and Eastern population is mixed stones, but with a slight preponderance to cholesterol stones in North India and pigment stones in South India. So North Karnataka, so you can see 1, 2, and 3, which is mixed followed by pigment followed by cholesterol. The studies also try to explain what is the etiopathogenesis behind the cholesterol stones. So what is primarily happening is that cholesterol, we know bile is a physiological aqueous solution which acts as an emulsifier for cholesterol. Once the cholesterol content keeps on increasing, the load keeps on increasing, supersaturation of bile happens, excess cholesterol, nucleation of cholesterol happens. Nucleation means liquid form becomes crystallized form. This is the intermediate part over here. This is what, just a second. This is what we're seeing over here. This is the cholesterol monohydrate. It's form an important component of cholesterol stones. This biliary sludge is what we can catch hold in an ultrasound. And if left untreated, they eventually go on to form a microlithiasis and a cholelithiasis as well. And this is one very fascinating study done by Ramanamaya ma'am and et al. There's included crystal researchers from Anna University and physics department from Amity University and medical gastroenterology from Global. And they analyzed the exact chemical composition of the stones which was developed. So they named these, the first two you can obviously see, this is pigment brown, this is pigment black. The last three is more of cholesterol stones. So they labeled them as G1, G2, G3, G4, G5, and they went through 4 processes: X-ray diffraction, scanning electron microscopy, and then the infrared spectroscopy, and also the nuclear magnetic resonance spectroscopy. The first 2 stones, obviously pigment stones, did not have much of cholesterol in it, and they were anhydrous, amorphous in nature. And the G3, G4 and G5 were anhydrate. The cholesterol content was higher in these cholesterol stones. As they were subjected to spectroscopy, cholesterol stones, obviously you can see the cholesterol spike over here. Mixed stones having both the spikes, and pigment stones have predominantly bilirubinate in them. Calcium crystallizes the bilirubin to form this calcium bilirubinate. So this is how etiopathogenesis of pigment stones occur. So what studies say that bacteria means infection of the bile. Main contributor to infection of bile is bacterial organisms. So bile, you have bilirubin glucuronide, which is broken down by bacteria into free bilirubin. Phospholipids, phospholipases, free fatty acids you have, and then conjugated bile salts are converted into unconjugated bile salts. And all these 3 club together to form the pigment stones in addition with calcium. This calcium gets crystallized with bilirubin to form calcium bilirubinate. Most of the component of pigment stones are also calcium bilirubinate. Owing to this infection, the most common being Klebsiella, E. coli and Pseudomonas in aerobic organisms, and anaerobic is owed to a large amount of facultative anaerobes. So if you remove infection out of the play, the second most common cause of pigment stones will always be hemolytic disorders. If it is infection, you must always consider that first. So as you can see, as the spectrum moves more towards the pigment stones, bilirubinate content increases, more towards cholesterol stones, cholesterol monohydrate component increases. So this is a very recent study which included 7 different regions, and they tried to study the composition of bile stones, beginning from the Himachal Pradesh up to the stone belt of India. Up to Calcutta they took, and 2 institutes, one from AIJ Hyderabad from the south and the Cosmopolitan Hospital from the southern state of Kerala. So you can see the cholesterol stones having spikes in the cholesterol spectroscopy, while the pigment stones from the south does not have any cholesterol spike at all. So the next topic, owing to clinical presentation, I already established the decades are the 4th decade, mixed diet, more in red meat, and the primary presentation was biliary colic, which is confirmed in these studies. And how do they present? The most common presentation, 3/4 of gallstones is always asymptomatic. They're just an incidental finding. The second most common being biliary colic owed to the microlithiasis. The third one being acute cholecystitis, and a very small but a very important part of cholelithiasis is your gallbladder cancer also. So let's look at them one by one. So asymptomatic gallstones, also called as silent gallstones, 80% as present as asymptomatic gallstones. They incidentally detected. Nowadays they're risingly detected because of the rise of investigation modalities, namely ultrasound as well. They usually become symptomatic before a complication develops. But the key point is that they can become symptomatic at any point of time. This is a very interesting study done among surgeons. This does not involve patients alone. A group of surgeons, including postgraduate super specialists and APs, were asked this question as where what made them do a lab chole for these patients, for these asymptomatic gallstone patients. So what they said was, obviously they said lab chole, the ease of access, minimally invasive, early patient recovery and all that. But what made them fear the most was people who are at risk of developing these major complications, namely diabetic patients, transplant patients, and other immunocompromised patients. And the most thing which feared them was the development of choledocholithiasis. And the second most common presentation was microlithiasis, which is very small stones which does and obstruct the cystic duct, either comes back or is passed through the CBD as well. They present as biliary colic, which pain lasts less than 6 hours. This is a very age-old study which done 120 years back by William Mayer, which says there is no innocent gallstones. So even after a century, coming evidences prove only that gallstones have a clinical significance in this group of patients. There are 2 things we can do. We can wait and watch, or we can do an cholecystectomy as well. So one important thing we have to do is we have to study the natural history of these stones which are going. These are Western studies showing that the risk of biliary colic post 10-year period is 10% and 25%. This was NEJM in hepatology. Now let's look at the Indian population. Why do we fear an asymptomatic gallstone? Although the proportion is very, very small, the most feared dreaded complication is obviously a GB cancer. So when we look at the epidemiology of gallbladder cancer in India, this was PJ Chandigarh paper, and naturally the higher distribution of cholelithiasis is more in North India. I told the toxic environment owing to the low socioeconomic status, and also naturally they tend to develop more of GB cancers as well. With maximum concentration in the stone belt obviously, and this Kamrup district of Assam was more prone. Not only GB cancers, esophageal, cervical cancers were also high, owing to the toxic metal exposure and also occupational exposure in that particular district. So gallstones over a period of time have the risk probability to develop a GB cancer. Pertaining to the patient, we can say age, females, multiparous women, and obesity, all these factors. Pertaining to the GB, porcelain gallbladder, all these ductal malunion, Mersey's syndrome, and the xanthogranulomatous cholecystitis. And people who are carriers of H. pylori, typhoid, and nickel, and the metal toxins, and the occupational exposures, which I talked about. So what I can say is that not all gallstones lead to gallbladder cancer, but 80% of gallbladder cancer have an association with gallstones. So we can see an ultrasound image over here. We can see the GB, and we can see a lucent shadow, which is representative of the stone. This particular study was done to study the epidemiology of gallbladder cancer in South India way back in 2012 in Tamil Nadu, which found out that the incidence of GB cancer post a GB stone was around 0.5 in males and 0.6 in females. The common presentation was right upper quadrant pain, jaundice, and a palpable mass. And the most common site involved was the fundus of the gallbladder. So just adding to the points which I told before, it's an anatomically busy area, and the present at a very late stage, stage 3 and stage 4. By the time the mortality has reached 75% for 3 months as well. And poor response to chemoradiotherapy. It is highly chemoradio resistant as well. And this paper from Adair Cancer Institute draws data from 19 hospitals within the city of Chennai. And like I said, the prevalence is 0.5 in males, 0.6 in females, and the age group involved is 5th to 7th decade in South Indians, which is more or less similar to the North Indian population, which is 5th to 6th decade. So is gallstone a risk factor for GB cancer? Absolutely yes. The risk is 7 times higher, and it hastens the process of GB cancer. And the statement which I told before, 80% of GB cancers are associated with gallstones, and in younger population less than 40, the percentage is even higher. So this is a very interesting paper done at Tata Memorial Hospital. What they did was they just made a questionnaire to these patients about gallstone patients who developed this gallbladder cancer. They went to these gallbladder cancer patients and they questioned them whether they did have a gallstone or not. And they put this these questionnaires through a randomization study and found that there was definitely a very strong association. They called it as a causal relationship between the stones and the future development of cancers as well. So the etiopathogenesis, mechanical, chemical, and bacterial injury, all three contribute to risk of development of a malignancy as well. So our findings have major implications in preventive strategies. Our main idea is to identify this specific group of patients who are at more risk of developing a malignancy. So they developed a panel of single nucleotide polymorphisms, which are slightly higher studies. SNP-DX19 can predict the number of patients with gallstones who have risk of GB cancers as well. There are two things we can do. We can wait and watch. Whom we can do? We can asymptomatic patients, EF more than 40%, who are motivated for follow-up, and the wall thickness is less than 2 mm, incidentally discovered. One last study, which is histopathological changes in GB mucosa. This was done by pathologists. Like post-cholecystectomy, they removed the stones and the GB mucosa, and they found out which stones actually led to this GB cancer as well. So what they strikingly found out was that gallstones, typically multiple stones and stones bigger than 2 centimeters had a higher risk of causing these GB cancers. So by this way, there is a need to identify these high-risk groups, and prophylactic cholecystectomy is an effective option as there is no proper medical dissolution therapy. They only act as a bridge for these therapies. So you can see this chronic cholecystitic image against a Rokitansky stain. You can see goblet metaplasia in this metaplasia of the GB, and you can see the loss of architecture as in our architecture in the adenocarcinoma picture. As you can see, the x-axis, it can transform into chronic cholecystitis, which is benign, and the pre-malignant conditions, metaplasia, dysplasia, and finally you have the carcinoma. And the rise in the size of the stone with the risk of the carcinoma as well. And there are two things we can do. The first thing which I told, we can wait and watch, and we must definitely do a surgery if there is associated GB polyp, which is the translucent shadow seen over here, associated anomalous pancreatic biliary junction, and the stone is larger than 3 centimeters. If the gallbladder is calcified to form a porcelain gallbladder, and they belong to remote areas, namely Kashmir or Odisha, whatever we discussed in the prevalence studies. And if hemolytic anemia, be it an adult or a child, we always do a cholecystectomy. And typhoid carriers are at higher preponderance to develop this GB malignancy as well. So just summarizing what we discussed, asymptomatic individuals stone more than 1 centimeter, and all the risk factors we discussed before, if it is there, always cholecystectomy. If it is not there, asymptomatic individuals, we can wait and watch. Symptomatic individuals, along with dyspepsia, if the GB fraction is good, we can follow up the patient. If the GB fraction is less than 40, or if they develop any of the complications, namely cholecystitis, cholangitis, pancreatitis, we can go for a surgery. I'll discuss two special situations. One is in children. As much as in adults, etiopathogenesis in children is also not much developed. This paper was done at Sanjay Gandhi Postgraduate Institute, Lucknow. And they found the maximum cause of gallstones in children in India was non-hemolytic. This included a lot of etiology under that, children receiving TP and prolonged fasting, Crohn's disease, cardiopulmonary bypass and diuretic therapy. And very close to it, it was followed by hemolytic disorders of the children, namely sickle cell disease, hereditary spherocytosis, and the thalassemia major of children. So in children, what do we do? Infants usually present with symptomatic cholestatic jaundice. We can wait and watch. In children, it is usually a biliary colic type of pain, and in the adolescents, it was also a right upper quadrant pain. So in infants, if they are symptomatic, the stone has passed spontaneously, we can observe asymptomatic gallstones in children. If there is no improvement after 1 to 2 weeks, we do a surgery. Asymptomatic individuals, they're calcified, obviously surgery. Non-calcified, we do the scan again after 1 year. If it continues to persist, we do a cholecystectomy as well. And in children, I told you, and in adults also, I told you, if it is associated with the hemolytic disorder, always better to go for a cholecystectomy and follow up the patients. And the other special situation which I mentioned was in cirrhosis. Cirrhosis, obviously, the liver is gone, reduced bile acid synthesis, reduced phospholipids, and it will not be able to process the cholesterol load on it. And other factors which had a close association with cirrhosis was an HCV infection and MASLD related patients. And the GB motility was obviously affected in these patients. This was done at Kalingam Institute in Bhubaneswar, where they studied patients with cirrhosis. And what they concluded was that as the severity continued to increase, the risk of cholelithiasis also increased. So how do we manage them? Asymptomatic patients we can observe. There is no reason to do such a high risk procedure in an already immunocompromised patient. The symptomatic measures, if the CTP class is C or a MEL score more than 13, decompensated patients, it is a contraindication for lab chole. The CTP is A or B, MEL score less than 13, patient is stable enough, you can go for a lab chole as well. If these already poor prognostic patients complicate, we do non-surgical management such as percutaneous cholecystostomy or a US guided drainage of the GVT. If no complications, we can treat them symptomatically. What are the policies currently available in India? There are no proper guidelines or policies at present. Can we do surgery for all? No, it is unreasonable. Asymptomatic load is around 80%. Can we do surgery for none? No, because there is a risk of GB cancer transformation as well. So we should do a targeted approach where we identify these high-risk patients. And this paper was also done by a surgeon. This is for the need of prophylactic cholecystectomy in silent gallstones or asymptomatic gallstones. So they identify a group of individuals who should undergo this cholecystectomy. Predominantly females less than 60 with a life expectancy of 20 years and calculi more than 3 centimeters. And obviously the high risk areas which I discussed, and the presence of chronically obstructed cystic duct and presence of porcelain gallbladder as well. There are not a lot of Indian studies which discuss the primary prevention of gallstones as well. Cholecystectomy is secondary prevention of gallbladder cancer. We can do a primary prevention by preventing the gallstones from happening itself. These two are what we advise. One is dietary changes and one is weight reduction. And Western studies show these data. All these three are mentioned in Schlesinger, which was statin have been proven beneficial, and I told you caffeine lovers are at an advantage, and people with good concentration of ascorbic acid in the blood are protected from a cholelithiasis. So summarizing the literature which I discussed in the past 25 minutes, gallstones are defined as hardened deposits within the fluid of gallbladder due to imbalance between cholesterol, bile acids, phospholipids and bilirubin, leading to this process called as agglomeration of all these components. This is how cholesterol stones are found. The prevalence can range anywhere between 2 to 29 and the average being 12%, and the concentration of these cases are obviously more in North India than in the South Indian population. And demographic data, most of the studies agree that it is more common in female sex, and the age group is the 4th decade. Most common presentation is biliary pain, and demographic factors, risk factors with a positive association are high BMI, high weight, increased tamarind exposure in South Indians, pregnancy, OC pills, dietary changes, and lack of trace elements in the blood. And the stone composition, all Western and Eastern population, the most common is mixed stones. In the North Indian population, a higher cholesterol load, and in the South Indian, higher pigmentary stones respectively. And there is no innocent gallstone per se. We wait and watch if it is asymptomatic, the patient is motivated or a complication has occurred, or if the patient belongs to a high risk category, we operate in the fear of a malignancy. And the most common indication for surgical intervention was to avoid complications, and the most common complication cited was obviously choledocholithiasis. The most dreaded complication among gastroenterologists was malignancy, This high 17 per 100,000, this incidence is in North India. We come down south, it comes down to 9 to 100,000, most concentrated in the stone belt, and requires proper intervention as 3/4 of these cancers, meaning 80% of these cancers have a strong causal relationship with the gallstones as well. Coming to our own state, the prevalence is 0.5 in males, 0.6 in females, age group 50 to 70. And the histopathological study which I discussed, the increase in the number of stone, increase in the size of stone, and increase in the thickness of GBA, made them more prone to a risk of malignancy. And medical dissolution therapies are served only as temporary measures before the definitive therapy of cholecystectomy. So what are all the gaps in literature presently present at Indian literature? So there is no lack of standard guidelines of diagnostic measures or classification. So where both Eastern and Western studies have not fully understood etiopathogenesis of cholelithiasis, and the lack of guidelines pertaining to this huge chunk of population which is asymptomatic gallstones. And there is a lack of study following a natural history of asymptomatic gallstones. I'd also like to mention a very recent study guided by from ICMR. We're doing a multi-center trial involving 11 institutes headed by PJ Chandigarh. So what we're doing is we're following up this asymptomatic gallstone patients over a period of time and looking which of them become symptomatic, which of them go through a gallbladder malignancy, or which of them require a surgery itself. It's very similar to what UKPD does with diabetes or the CPDPC does with chronic pancreatitis. This will throw light on a lot of issues and a lot of information on how these particular stone patients develop cancer as well. Of the 11 institute, Madras Medical College is also one of them, and we've contributed 8 cases in the past month as well. And both in Eastern and Western studies, there is a need for more effective trials on preventive strategies, and there is limited research material on surgical management. And non-surgical emerging therapies are also coming up, namely the laparoscopic single-site surgery and the endoscopic nodes and microRNA therapy to alter the genes by preventing gallstones itself, and also stem cell therapy to prevent the gallbladder from getting damaged as well. So these are the reference articles which I have quoted or used for the current literature review. So when it comes to the gallbladder, movement is life, stagnation is death. Thank you for the opportunity.
That was an excellent summary of the Indian scenario about gallstones. Is there any difference in the type of gallstones in north versus south?
Yes, sir. North is predominantly cholesterol and south is predominantly pigment. But the scenario is changing because of westernization of southern diet also. Right, 10 years back, these studies, I'd like to call it as globalization. So now if you want Korean food, you can have it in the evening. If you want Thai, you can have it in the evening. So westernization is not so far ahead. We have all started eating all these high refined sugars and saturated fats. Recent studies are also showed that more saturated fats are also contributing to the cholesterol stones as well. So we will not be surprised, we are also more prone to gallbladder cancer.
You mentioned something about gallbladder ejection fraction.
Yes, sir.
Does it have any role in the practical management or a wait and watch policy in asymptomatic gallstones?
Yes, sir, very, very much. Asymptomatic stones, we can measure GBEF with hepatobiliary imidoacetic acid scan. With the HEDA scan, if it is more than 40, we can wait and watch in symptomatic patients and asymptomatic patients as well.
Any questions from the surgeons?
I think any further discussion, I think,
or
Dr. Jayanti, I think, must still, she's done the maximum.
Yeah, I've quoted around 4 articles from ma'am, I think. I should be very thankful to her.
So,
yes, ma'am.
yeah.
Yeah. Yes, yes.
So I think when you present also you should be suggesting here.
Yeah.
We don't appreciate our people and no one will appreciate
This was the presentation at Inasal, madam, at the oration. She brought all the...
oration on very nice, but you did a very good job.
Madam.
Your comment on that, yeah.
So the entire gallstone in India actually started from me in 1984. So we're all in the archives, you know. We're all in the library behind. The first time we saw when Dr. Ahmed Ali started bringing stones, we saw all the black stones. And the company was coming forward with UDCA for dissolution. So I should just throw them out, no? I said, get lost, this is not cholesterol stone. And then we saw they were all black. And then I linked up with Kerala, Karnataka, Andhra Pradesh, and all were black. So the takeoff of the North Indian gallstone study is actually from my study. Because theirs was cholesterol and ours was black. Understand? We completed all. We've done the lithogenicity of the bile, all that you have to mention, the bile acid composition,
Yes, sure.
everything, all the composition. Then I went to Coimbatore. Dr. Parnivel helped me with the stones, and he helped me with the analysis of the bilirubinate, what was the proportion of cholesterol. All the paper was done from which center? Government Peripheral Hospital, Anna Nagar. You understand? Not from any premier institution. So when this study came out and we started publishing this data, the North Indians started taking off from there. So when they talk, India is not one country. In fact, I believe India's got several countries. Each is a country. So when you make a statement, that in India, it's north and south. Many diseases, ulcerative colitis in north, Crohn's in south, celiac disease in north, tropical spread in south. So all the diseases are different in north and south. So you should not make, so in the exam, when North Indian examiner was coming, and if there's an obstructive jaundice, and if you did not mention gallbladder cancer, you would fail. And only then when all these papers started coming up, now we are recognized as stones totally. All the papers that you quoted are all takeoffs from what we started at Peripheral Hospital. I think that is something very important. And gallbladder cancer I've done in Stanley. It was just out of 100 cases, we had only 2 cases which came out to the gallbladder cancer. I did a retrospective analysis.
Yes.
So ours was just 0.2%, that's it.
Yes.
So I think all these things are very important, that you have to talk region-wise. You have to talk region-wise. If you're, for the candidates, many of the North Indians are now settling in South. So we should be aware of the gallbladder cancer risk. So both knowledge, the knowledge is important. So when Rakesh Tandon, I told him to analyze my stones. So what he did the South Indian stones in North India. And the South Indian population that settled in North India were all black stones, which means that environment, they're all settled there for more than 2 decades, which means that it was a genetic. So there's a problem. It's not the gallbladder, it's not the culprit. Gallbladder is finally forming the stone. The problem is in the liver. Why do you get supersaturated cholesterol? Why do you get high bilirubin? It is all genetics. It's a gene. So then I asked Dr. Seshadri and I asked our pediatric colleagues from ICH. I got about 42 stone data, all black pigment. And I asked Dr. Seshadri, the ideal center which had northeastern stones. And he came out with the same information. From south, it is black. But in north, in children, it was still cholesterol. It's cholesterol, which means what? The whole thing is genetic based. Otherwise, the children should have pigment. That Poddar's is actually a review article. And you mentioned infection. No hemolytic in South Indian stones. We've done that study also. Bacteremia is almost not there. Okay, not even 10% has got infection. We've done scanning electron microscopy. No bacteria, no dead bacteria found. So it is 99.9%. There's a gene that's probably either in the cholesterol pathway or in the bilirubin pathway that is causing the supersaturation of bile or supersaturation of the bilirubin. That's forming. Gallbladder is only forming the stone, but the culprit is there. I think so. Therefore, just be careful about this. Therefore, when a South Indian comes with gallstones, we are not worried about the gallbladder cancer. We are not worried. They are very distinct entities. Suppose the fellow is going to US and settling down. I'll say remove your gallbladder. He has problem there. A pregnant, a newly married has got stones and is likely to conceive and all, remove the gallbladder. They're all definite indications. Otherwise, as such, I stand to correction Dr. Shankar, but this would be my approach to any patient gallstone. And I think, as Malti said, one is women have to be lifted up. So I was lifted up at the NASL. Okay, so I was one of the first lady orator there. So it was one unique occasion. I just could not believe, that I was giving an oration there. It was unbelievable, okay, because It was about 32 men ahead of me, and I was the first lady to give that oration. So what I'm trying to say is, one is hard work, number one. Number two is, I think, important is recognition. I know we should recognize our own people. That's something we always lack. And all your multinational study of ICMR has all been mooted by me. Yeah, but we lie low, right? Okay, thank you. Ours is all black and amorphous.
The algorithm.
Yes, madam. Actually, the way in which a physician approach a gallbladder stone is different from way in which we surgeon approach, because finally we face the music. Because the most miserable time that we surgeons, laparoscopic surgeons, have is doing a difficult gallbladder. Because as you all know, that the most common elective operation done all over the world is laparoscopic cholecystectomy. All over the world. And laparoscopic cholecystectomy in a biliary colic patient is a straightforward, simple operation. It gets over in 30 minutes or 45 minutes at the maximum. On the other hand, if the patient develops an acute cholecystitis, it becomes very dangerous. Sometimes it takes 2 hours, 3 hours, 3.5 hours. And rarely we have to convert also. We have to do subtotal cholecystectomies. That's where you injure the bile duct, more bleeding. So that's why whenever I see a patient, young patient with a big stone, I don't have any hesitation in, even if it's asymptomatic, I suggest surgery. Because we don't intimidate the patient by telling that we are doing surgery for the prevention of gallbladder cancer. That's not science. But still, they develop complications of gallbladder stones. But we also know that the size of the stone doesn't matter in the development of complications, because very small stones are very dangerous because they produce pancreatitis. Big stone sits within the gallbladder, will not come out of the cystic duct and produce cholecystitis. So, I mean, I think, I think Dr. Shanmunan will agree that of late, he is also of the opinion that there is nothing called asymptomatic gallstone, because we have to dig into the history. All patients need not present with the classical biliary colic. So, I think we have to be a little practical.
Coming to Dr. Shankar's word about me, actually many patients with gallstones come, whenever they come, we look for regular history of biliary colic. And one thing is patients always live in denial. They just deny pain. They will just tell, yes, I had gas. I had gas for 5 minutes. I had antacid. It came once a month, like that. Deeper and deeper questions, I think many of these presumed asymptomatics may actually be symptomatic. I don't know how many of the audience will agree with me.
Very nice. Thank you, Doctor.
Next, before the next session, want to award the certificates. First to Dr. Tarun George by Dr. Sheshadri. Dr. Tarun George.
His left.
Dr. Harshvardhan, Dr. Joseph.
Double round of applause. Medicine.
Dr. Akhil Chaudhary by Dr. Shanti Selvi.
You got one,
no? Dr. Sunil Kumar.
the chairpersons will share.
I thank all the presenters and the chairpersons for conducting the postgraduate session. It was wonderful, and I would request Dr. Sunil Kumar to write it up, including the suggestions that have been given by the esteemed panelists and the persons here, to write it up as a literature review for our journal, GHEP. So, moving on to the second part. Before that, we just have a short secretary report that I would like to present. I think last month we had a wonderful meeting in association with Chennai US Live. We could get 3 national faculty to come around and be part of our Tamil Nadu ISG meeting, and taking a big congratulations to Dr. Vishnu. And last week we had a Tamil Nadu ISG endorsed poem workshop done by Dr. Lognathan. A big congratulations to both. And since Madam has already told she, I mean, we have to, as one more feather to her cap, she was awarded the INSL oration, and it's again a big thing to cheer about. Ongoing, I think Plex study is ongoing. I think this is the last month. They're collecting the data. I hope we'll be able to publish this sooner. The most important thing is our Tamil Nadu midterm ISG meeting is on October 19th and 20th at Kutralam. The program details will be out in a week. They're making the final corrections. Please make your travel arrangements at the earliest, because there are limited train or flights available to this area. So please make your travel arrangements. And the annual Tamil Nadu ISG meeting will be on February 22nd and 23rd in Coimbatore. In the meantime, in the national level, we have the ISG Con, which is coming up at Varanasi from December 4th to 7th. And for that Tamil Nadu midterm meeting, there will be a poster session for the postgraduates. And I request all the postgraduates who are going to attend to put up a poster there. So that will be a good educational activity. And before I end, I request all of you to scan and give your Tamil Nadu Medical Council attendance. It takes only a minute, require 4 details. Thank you so much. Move on to the CME part. We have 3 interesting lectures to conduct the CME. This will be on abdominal pain. It's very common. There are certain clinical aspects, there are certain newer mechanical aspects that have come up, and also about interventions to control the pain relief. So to conduct the proceedings, I'll request Dr. Ratnaswamy and Dr. Padmanabhan, senior consultants from the surgical and the medical field, to conduct the proceedings, please. Thank you, sir.
Good evening to each one. Good evening to each and every one of you. At the outset, we thank the organization for giving us the opportunity, and it is our privilege to call Dr. K.R. Palaniswamy, Senior Consultant Medical GE Apollo Hospital, to give the talk on clinical pulse acute abdomen. He is a gastroenterologist of international repute, and in the International Forum of Gastroenterology, his name ranks first. And he talks on a very important topic, clinical pulse. And I request him to deliver his lecture.
Good evening. Sorry, I have a bad throat. Still, I'll try to manage. I would like to thank Perumalayam Secretary and TNISG for the opportunity. After listening to the complex case presentations and also the literature review, I'll be probably discussing common clinical scenarios and regarding the clinical pulse and pain abdomen. As I'm going to discuss about 6 cases, among them, few of them had a atypical presentation, others had a typical presentation. I shall start with the first case. This is a 6-year-old male, and he complained of the pain upper abdomen and usually have complaints of pain mostly in the night only, not daytime. And pain was severe, used to last for several hours, and there was no radiation, no fever, and the patient was transferred from other hospitals to Apollo Hospital. He came with the investigations done at the other hospital, and the labs were normal. All the laboratory investigations were normal. Imaging, he had ultrasound, CT, they were all normal. And he had upper GI endoscopy, colonoscopy, capsule endoscopy, all were normal. And he had a recent IT rate. So one of his close relatives was a doctor, general practitioner, and he just told me that he had an IT rate. This pain must be psychological. So clinical examination, no physical signs. And daytimes he used to just look at the computer. He used to search in the web, the Google search for, he's a real estate man, look for all the land wherever is available. Night he will have pain. So I just want to know, this is a clinical scenario. Any postgraduate can comment, what is the next step? How will they take forward? Anybody? Then I was wondering what to do. So I thought, let us repeat a CT scan. I repeated a CT scan. That time we had a 320 slice CT, now we have 640. And that showed a small calculus in the GB neck. But we can't attribute this for the pain. He had no evidence of any sort of inflamed gallbladder at all. He had several ultrasounds. So that was the situation. He was in the ward. And his son-in-law was a surgeon, and his Sambandhi was a doctor. Then I told my registrar, next time, whenever he has a pain in the night, maybe in the middle of the night, please call me, I'll come. So I was called in the early hours, like at 2 o'clock. I went to the hospital, examined him, and he had pain, tenderness over the right hypochondrium. I took him immediately to the ultrasound. Ultrasound showed pericholecystic fluid. The next morning by 7 o'clock he was operated. That was a cholecystitis. So the lesson here is, you can't dump anybody as a sort of a psychiatrist. The pain is psychological unless proved otherwise. So you have to prove beyond doubt. That's what I think the lesson should learn. See, normally gallbladder pain, as you all know, it is mostly in the upper abdomen, epigastrium. Any sort of a visceral pain, it can start in the periumbilical region, and then it can settle to wherever the pathology is. Usually epigastrium and right hypochondrium, and it can radiate to the back, to the right of the back, and the right shoulder at times. And sometimes you can have atypical presentation, and sometimes it can mimic a cardiac pain. There are situations where patient presented with cholecystitis, where it mimicked a cardiac pain. And when there is a choledocholithiasis, when there is a stone in the common bile duct, where pain can be epigastric, at times it can radiate to the retrosternal area. So I shall move on to the next case. This is a young girl. This patient I have seen during my early practice days. It was late 80s. And she was about 8-year-old girl. She used to get recurrent pain abdomen. And she was seen by many doctors. And she had several investigations. She had multiple ultrasounds, CT scan. And those days, ultrasound was the initial stage. Only Dr. Suresh used to do the ultrasound. And when she came to my clinic, of course, she had a weight loss and no fever. She used to have vomiting. And her gait, she was she just walked bending forward, and she lost weight. She was looking sick. And by the time she came to me, she had all investigations possible, and she was referred to a psychiatrist. I was wondering what to do. So since she had a pain abdomen and also weight loss, then I thought it may not be a psychiatric problem. So the only investigation which was not done was the upper endoscopy. So I did the upper endoscopy in my office in the clinic at that time. It was a fiber optic endoscopy. She had an extraneous impression in the posterior wall of the stomach. Then I called Dr. Suresh. I said, this is a finding. Can you repeat the ultrasound? And he repeated the ultrasound. It was a pseudocyst. And we recommended surgery. She preferred to go to the US because she had some relatives there. She went there, she got operated, and she had small stones in the pancreatic duct. And recently, she brought her daughter to me for consultation. So pancreatic pain, as you all know, it usually in the upper abdomen, epigastrium, usually radiates to the back. Some situations you may not have the radiation to the back, where it can be atypical, it can be a focal pancreatitis, chronic pancreatitis, or even group pancreatitis. The next case is a 56-year-old male, diabetic. He had a recurrent pain abdomen, which was intermittent, and it was from the left hypochondrium to the left lumbar region, lasting for 1 to 2 days, associated with constipation and abdomen distension. But it used to settle in 2 days, and followed by every time it was followed by a bout of loose stools. Any guess what could be the diagnosis? Anybody? Sorry? Diabetic, no. And here the pain is almost starting from the left hypochondrium, moving down, and then associated with constipation, relieved by having a sort of a bout of loose stools, probably related to bowel. Sorry? Yes, possible. So on examination, the patient had a distended abdomen, and he had a palpable bowel loop. It was a colon, and labs were normal. A patient came with a CT scan, which was done outside, and which showed a focal dilatation of a distal transverse colon and descending colon, suggestive of an inflammatory stricture with upstream focal bowel dilatation. And this was the plain X-ray when he came in, and this was suggestive of a valvulus. And he was operated, and he did well post-surgery. Generally, bowel pain, proximal, when there's a pain due to proximal bowel, it can be intermittent, colicky, can be associated with distension and vomiting, it can be bilious. If it's a distal small bowel, vomiting may not be a prominent symptom, and there may be more distension. Rarely, the vomiters can be feculent. And when you do a CT scan, sometimes you can see the small bowel fecal sign. When the pain is due to colon, generally colonic pain can be usually with the colonic obstruction. Of course, commonly with a colonic pain can be due to diverticular disease, diverticulitis, or when there is a colonic obstruction, they can present with pain. Recently, we had a patient had a pain of 1 month duration. Patient was seen outside, and patient had a constipation, distension, and she had some dyspeptic symptoms also. And patient had an upper endoscopy, and she was prescribed PPI. When the patient came to us, he had a distension, palpable colon, and finally the diagnosis was a stricture, that is the rectosigmoid stricture, which was a malignant stricture. And he had a total colectomy and ileostomy. The next case is a 73-year-old female. She came to emergency with acute severe pain abdomen, and she had a fever, and there was no vomiting, higher imaging, and even with a light touch, a gentle light touch, she was jumping with the pain. So that was suggestive. I mean, it is not a simple problem. Maybe it can suggest peritoneal irritation. And CT scan showed free fluid in the abdomen, and also it was suggestive of a GP perforation. And later, where she was taken up because she was a very sick patient who had a lot of comorbid issues. She underwent a percutaneous cholecystostomy, and peritoneal drain was placed, which was bilious. So the lesson is, diffuse pain abdomen, when you examine, even with a light touch, if you have a sharp tenderness, you should not hesitate, you should not skip or miss the diagnosis of peritonitis. So pain of peritoneal origin, it can be diffuse and even it can be tender on light touch, and later they may develop guarding, rigidity, and bowel sounds may be absent. The next patient, 78-year-old male doctor. He practices in the United States. He was here on a holiday. He had a pain. He came with pain abdomen, pain more of upper abdomen. Pain was intermittent, colicky. It usually starts 2 hours post meal, and it used to be associated with episodes of vomiting, and also vomiters used to be non-bilious. And he had a travel from USA. He had a self-intake of warfarin, 5 milligram on alternate days for DVT prophylaxis. And on clinical examination, he had no localizing signs. Per rectum was empty. Because of then we went to investigate labs. If you look at WBC, elevated white cell count, urea creatinine elevation, mild elevation, and liver function normal, lipase normal, ultrasound showed a grade 1 fatty liver. And we asked for a CT scan. We did a plain CT because he had raised urea and creatinine, so we didn't want a contrast. Plain CT showed atrophic pancreas, pancreatic parenchyma with peripancreatic fat stranding. In addition, he had a dilated that is third and fourth part of the duodenum, and proximal jejunum appears prominent. That was the additional finding which was noted. And during his admission, 5th day of admission, he had severe colicky pain abdomen. On clinical examination, heart rate was 120. Per abdomen, he had guarding, epigastric tenderness, and absent bowel sounds. And hemoglobin dropped to 8.3 grams. But he had no, RT aspirate was not bloody, and no melena. What could be the reason? Anybody? Sorry? Yeah, it is possibly a intraperitoneal bleed, possibly because he was on warfarin, and he had sort of now presenting like bowel pathology, like ischemic bowel. So we repeated the CT, plain CT because of the renal issues, and that showed diffuse circumferential wall thickening of proximal jejunal loops with prominent vasa recta, and with standing and edema of the adjacent mesentery, with mild wall thickening of the D3 and D4. And pancreas had a similar finding, atrophic pancreas, and he had ascites. Impression was features may suggest infective, ischemic, or inflammatory process of jejunum, and they did suggest a contrast study. So this is a clinical scenario. What will you do? Will you go for a contrast study, taking precautions? Looking at the clinical scenario, he is very sick. Any suggestions? So we decided to go for a surgery straight. And surgically, he had a proximal 30 centimeter of jejunal loop was gangrenous. He had a hemoperitoneum, 1.5 liter of fresh blood oozing from mesentery of a gangrenous jejunum. And histopathology was ischemic bowel. So, what is the characteristic feature of ischemic pain? Typically, it's a postprandial. The most important thing is they may have symptoms, but they may have less clinical signs or no clinical signs. So that is a characteristic feature of ischemic bowel. And mostly the diagnosis based on the history and also other comorbid issues. Of course, the diagnosis can be confirmed by imaging. Sometimes imaging may not give a conclusive diagnosis. At that situation, based on the clinical scenario, you may have to go for a surgery. Maybe start as a laparoscopy and then proceed. The case 6 is the last case. Is a 57-year-old female, and she had a left-sided pain abdomen of 10 days duration. Pain was insidious onset, dull aching, non-radiating, partially relieved by painkillers, aggravated on movements, body movements. On clinical examination, she had a tenderness in the left upper quadrant, also over the left lower the rib cage. Any suggestions on diagnosis? It's simple. Yeah, it is a parietal, possibly a parietal pain, because here the characteristic feature here is an associated pain over the lower rib cage also, and she had tenderness also. And when she came in, she had investigation done. Labs were normal. Ultrasound showed fatty liver, gallbladder stone, and she had an MRI, MRCP, fatty liver, cholelithiasis. So she came to us with possible, because outside they have told it's a gallbladder problem, suggested recommended surgery. So here, with this sort of a clinical scenario, the pain was not due to gallbladder, because left-sided pain presenting like a parietal pain. So then we said it's only a parietal pain. We deferred the surgery. And in these situations, to confirm the diagnosis, always you can repeat an ultrasound. Ultrasound you can do for us soft tissues. Of course, ultrasound showed gallbladder stone, and left lower costal and abdominal wall had a wall in the left hypochondrium had the muscle planes were hypoechoic, suggestive of inflammatory pathology. Even ultrasound can pick up even the muscular tear is also can be picked up. So parietal pain, generally the history is the most important here, and that can help you to make a diagnosis. So you should take a detailed history. And also the other important thing is you must ask about the past history. Suppose your patient is a regular the gym goer, he probably lifts heavy weight, he comes to you with pain abdomen. I had a similar situation. One patient came with a severe pain abdomen. That was because, again, parietal pain due to muscle tear. He lifted heavy weight and probably he landed with a muscle tear. And the other important thing is this pain can get aggravated by movements or moving to the sides or bending forwards. They can get pain. That can suggest it could be a parietal pain. Of course, the Carnot sign that you are all familiar. So whenever you suspect parietal pain, probably you should ask the patient to lift the head or both the legs. At that time, probably parietal pain can be sort of easily diagnosed. And the other important thing is neurotic pain when there are shingles, where sometimes, that's again elicited by a light touch. Other important thing is you should examine the back, where unless you examine the back, you can miss shingles. That's again important thing. So I would like to end with this comment, with a quote by Lawrence Brandt. About 2 to 3 times each year, I get asked to see a patient with chronic, unresolving, and undiagnosed pain abdomen. Invariably, these patients have seen several gastroenterologists before me. So they have had many CT scans in addition to the requisite EGD, colonoscopy, and that almost all gastroenterology visits today. That attends almost all gastroenterology visits today, and have been unsuccessfully treated with proton pump blockers and variety of pain medications, sometimes including narcotics. That's true. The one thing these patients may not have had is a thoughtful and compulsive abdomen examination. That's important even today. Today, I think many of us, or even many centers, not only in our country, even overseas, we diagnose from a distance. Once I was just going with the ward rounds in Mayo Clinic. So they just, in the nursing station, they discuss with the patient about the patient detail. They just go and talk to the patient. They don't even touch the patient. So that is the clinical scenario today. We have to examine the patient. In fact, as I was examining the abdomen of the last such patient, I saw with these complaints. He looked up at me and said, "You know, Dr. Brandt, you are the first doctor who has touched me." So that's where probably we should take a lesson, learn a lesson from this. I think we should take a detailed history about, especially most important for the postgraduates, and examine the patient. And one more important thing I want to tell you, when a patient comes with all the big records, but generally when a patient comes to you, he will immediately give you the records. Don't take the records. Always tell them, I would prefer to see you, examine you before I go through the records. I have to form my own opinion. So that's the most important. So with this note, I would like to thank once again and Secretary and the TNISG for the opportunity. Thank you.
Thank you very much, sir, for emphasizing the importance of clinical examination at the present situation. Now the art of clinical medicine is considered to be a endangering or vanishing or extinguishing subject. It is a very pity, and almost in many places, graveyards were built for the clinical medicine. At this situation, with your vast experience, you have very nicely emphasized the importance of clinical examination. Do not allow the investigations to supplement, to supplant. Investigations are only for supplementation and not supplant our brain. Thank you very much, sir.
Thank you.
William Osler, quote, "Listen to the patient. He is telling the diagnosis." Thank you very much,
Thank
sir.
you, sir.
Thank you for presenting a variety of cases with abdominal pain and stressing the importance of clinical examination. And as you said, repeated examinations in different intervals will
Not
help
only
you.
repeated clinical examination, even the investigations, initial investigations can be negative. You should have follow-up. Like our first case, where everything was negative, but you should follow up. Clinically, again, reevaluate, do the investigation again. You will arrive at a diagnosis.
Any comments?
Thank you.
Thank you. Now we will go for the chronic abdominal pain. To talk about newer mechanistic pathways and treatment options for chronic abdominal pain, I will call upon Dr. Raghavendra. He is a consultant medical gastroenterologist from Southern Railway Hospital. Doctor, the floor is yours.
Good evening, everybody. Myself, Dr. Raghavendra. I bring warm greetings from Southern Railway Hospital, Perambur. There are no financial disclosures in this talk. So my previous speaker, KRP sir, excellently captivated the audience with a case-based discussion. And for this talk, my topic is on newer treatment, mechanistic insights and resultant treatment options for visceral abdominal pain. When Dr. Perama sir, asked me to do this talk a couple of weeks back, I was like, I asked sir, is this something to do with IBS? I'm not sure. Can you please guide me? And he sugarcoated me into accepting this talk by sending me some articles. And my reaction after reading those articles was I had a very good sleep that night. So, and the next day I realized that it's going to be a difficult task to engage the audience for 20 minutes about the various pathophysiological mechanisms involved in visceral hypersensitivity and visceral pain. But I would like to simplify the talk as much as possible and then try to put out the mechanisms So hopefully by the end of this talk, we'll all have a brief understanding of what exactly we are dealing with when we mean chronic visceral pain. So chronic visceral pain, it's one of the most common reasons for patients with gastrointestinal disorders to seek medical attention. It causes a substantial burden to the patients, also contributing increased direct as well as indirect healthcare cost. Few basic definitions. Pain, as we all know, is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. It could be acute or chronic. It could be somatic or visceral. Other few definitions which we should know is hyperalgesia, which is defined as a heightened response to painful stimuli, and allodynia, which is a pain arising from a non-painful stimuli. Chronic abdominal pain, for all purposes, is taken as pain which is persistent for more than 3 months. More than 70% of our patients with IBD experience abdominal pain during an acute flare, and around 20 to 60% report chronic abdominal pain. The chronic visceral pain is one of the hallmark of the DGBI, that's the disorders of the gut-brain axis, affecting around 40% of the population, predominantly women. So I would like to spend some time on this slide because this picture actually shows a bird's eye view of what we're going to go through in the subsequent slides. Chronic visceral pain, as we discussed, is a disorder of the gut-brain axis. Triggers include stress, psychological comorbidities such as anxiety or depression, diet, low-grade intestinal inflammation, and microbial dysbiosis. Basically, if you see this slide, the nociceptors are basically the pain-sensitive neurons or the visceral afferent nerves. These have the cell bodies in the dorsal root ganglia. These have pseudo-unipolar axonal projections which can go to the intestine or to the spinal cord. There are ascending pathways in the spinal cord which end up in the brain. These ascending pathways are again modulated by descending pathways which arise from the hypothalamus and the midbrain. If you look at the diagram on the right, this is at the level of the mucosa where the nociceptors are innervating the nerve terminals. These nociceptors are activated by a variety of different mechanisms. For example, it could be directly, the nociceptors can be directly activated by the inflammatory substrates or chemokines, cytokines, everything can activate the nociceptors directly, especially if there is a breach in the mucosa. Or it could be indirectly activated by the cells here, the enterocytes or the enterochromaffin cells, which in turn lead to the nociceptor nerve terminal activation, resulting in neurotransmitter secretions like substance P or CGRPs, which in turn will activate the second order neurons in the dorsal root ganglia and ascend further. So building on this pathophysiological framework, we will now focus on the recent advances involved in the peripheral pain sensing mechanisms. Also, we will be dealing with the specific physiologic and the pathophysiologic peripheral mechanisms that have been translated into receptor-based treatment approaches. These treatment approaches concentrate mainly on the, target mainly on the receptors or the intermediate cells or both. And there are newer targets which involve the peripheral pain sensing mechanisms per se of the various different underlying GI disorders. So I'm going to discuss the individual mechanisms in detail. First, we'll see the physiology and pharmacology of pharmacological mechanisms, then the preclinical and the clinical data for each of these individual mechanisms. First, guanylate cyclase C, GCC, as it's fondly called. This enterocyte receptor GCC plays an essential role in fluid secretions, barrier functions, and nociception. In this diagram, you can see there are basically 4 secretagogues. Secretagogues are drugs which cause increase in water secretion in the gut. One is the chloride channel activators, AYC2 channel activators like lubiprostone. The other is CFTR channel activators like linaclotide or plecanatide, and its newer cousin plecanatide. The other is tenapinor, which is a sodium hydrogen exchanger inhibitors. These are the 4 molecules which cause an increase in chloride secretion in the gut, and thereby increasing gut motility, primarily used in the treatment of IBS constipation as well as chronic idiopathic constipation. Coming to GCC, GCC receptors are basically found in the apical surface of the enterocytes throughout the gastrointestinal tract. And these are activated by paracrine hormones like guanylin or uroguanylin. Once activated, these channels triggers the enzymatic conversion of GTP into cyclic 3' cyclic GMP, which in turn activates the protein CFTR, cystic fibrosis transmembrane conductance regulator, which leads to a chloride secretion into the gut and thereby increases the motility. What we know from the preclinical studies, linaclotide, which is a GCC agonist, it has been shown in animal models that it decreases visceral motor response to colorectal distension in both acute colitis and stress-induced models of visceral hypersensitivity, meaning once you have you cause colorectal distension, these agents act through the GCC receptors, decreasing the visceral hypersensitivity. Conversely, what they were able to demonstrate is in GCC knockout animals, these effects were abolished, meaning these agents are quite specific. Also, linaclotide or a direct application of cyclic GMP to an in vitro preparation of nociceptor afferents, similar responses were observed. Interestingly, these GCC expression was not found on nociceptors, meaning these anti-nociceptive effects were quite indirect. If you remove the mucosa, linaclotide or uroguanylin stimulation from the stimulation of cyclic GMP release was abolished. Coming to the human data, this is one trial from, this is a meta-analysis done by the Black CJ group, published in Gastroenterology in 2018. This is, shows a forest plot here of the various drugs which I just told. Linaclotide is a prototype. It's a 14 amino acid peptide which is similar to the two gut hormones, guanylin and uroguanylin. The newer cousin plecanatide is a more pH sensitive drug. Dosages of linaclotide is 290 micrograms for IBS-C and 72 and 145 micrograms for chronic idiopathic constipation. Plecanatide is used in a dosage of 3 and 6 milligrams. What you can see in this forest plot is that both linaclotide, Lina and Plica, they were more efficacious than placebo for the US FDA recommended endpoint of abdominal pain, which was defined as a 30% improvement in abdominal pain in more than 50% of the weeks. The significant adverse effects of these drugs is diarrhea, which was seen in around 20% of the patients with Lina and 6% of the patients with Plica. On further developing this drug, they tried to develop the delayed release forms of linaclotide. It was developed on the premise that a more ileocecal ileocecal delivery of this drug would target the abdominal pain without affecting the bowel habits. But as you can see in this graph, it was not superior to placebo. So even the immediate release formulations of linaclotide were equally effective. Moving on to peripherally acting opioids, the next ones. Opioids are an important class of drugs used in pain management. Opioids, they act on through 4 G protein coupled receptors. The DARs, delta opioid receptors, MARS is the mu opioid receptors, CARS is a kappa opioid receptors, and NOPRs is a nociceptin opioid receptors. Once these receptors are activated, it leads to G protein signaling and formation of a multitude of intracellular proteins called as beta arrestins, and these cause further ion channel modulations and inhibit the action firing, inhibit the action potentials, thereby decreasing the visceral hypersensitivity. The analgesic effects of the conventional opioids can be strong. For example, morphine or weak codeine mainly act on the MOR receptors, to a lesser extent on the COR and the DOR receptors. But the problem with the conventional opioids is they have a huge addictive potential and they are full of adverse effects like respiratory depression, constipation, and other things. Also, with the use of conventional opioids, people develop tolerance over a period of time. And there is a phenomenon of opioid-induced hyperalgesia where dose escalation leads to an increase, paradoxical increase in pain. These problems are again further worsened by the opioid crisis in the West. So the search for peripherally acting opioids which can act in the periphery, avoiding these side effects were developed. So these basic strategies to develop the peripherally acting opioids was through either you restrict the access to the drugs to CNS by creating charged molecules. Loperamide is a good example. It's a MOR agonist which acts peripherally. But till date, however, these have not shown to have any good analgesic effects to be clinically useful to treat visceral pain. Loperamide, as you all know, it's widely available over the counter, and it's used for improving stool consistency as well as frequency in diarrhea. So the other strategies were to target the opioid receptor heterodimers through drugs like prototype drugs like elixodolin, which is a new kid on the block. It's a specific MOR agonist and a DOR antagonist with weak affinity for CARs. Basically, these receptors are co-expressed on nociceptors. The MORs and the DORs, these are co-expressed on the nociceptors, and the drug shows a high binding affinity to both the heterodimers in cell assays. This is what they can able to show. But there has been sparse mechanistic trials on whole animal models with this drug. Other strategies were to develop safe opiate drugs, meaning use the endogenous opioids with the use of, say, encapsulinase inhibitors to develop pH-sensitive opioid analogs which act only at the site of inflammation. Also, combination of subthreshold opioids and cannabinoid CB1 receptor agonists, which I'll be dealing later, also can provide strong analgesia without adverse events. And the use of nanotechnology, nanoparticles coated opioid cargoes, which can deliver the drugs to specific sites intrarectally to limit the central nervous system side effects, were tried. Despite the widespread use of opioids, fewer trials have reported the abdominal pain outcomes. And loperamide is one drug which has been tried in IBS diarrhea as well as in IBS unselected patients. There were two RCTs, one 13-week RCT and the second 3-week trial, in which it was shown that the pain scores were significantly lower with loperamide as compared to placebo. In another trial where they reported the number of painful days were reduced significantly, but not the severity when these patients were treated. With elixodolin, it's used in a dosage of, tried in two different dosages, 100 milligrams BID or 75 milligrams DID. The 100 milligram BID dosage was found beneficial, was shown to be beneficial in a meta-analysis where it was superior to placebo. The only caveat of this drug is that patients who have undergone cholecystectomy, that is, those patients who don't have a gallbladder or patients who consume alcohol, more than 3 drinks in men or 2 drinks in men, they were found to have an increased incidence of pancreatitis. In patients who have undergone cholecystectomy, there was an increased incidence of SOD. Moving on to the microbiome and the visceral pain. The gut microbiota derived metabolites, neurotransmitters, toxin, and cell wall components, these have emerged as potential factors underlying the pathophysiology of visceral hypersensitivity. These compounds can again act on the different ways, like I mentioned before. They can act directly or indirectly through the cells. Once activated, they act through multiple signaling pathways, and the gut microbiota can both synthesize as well as use neurotransmitters like excitatory neurotransmitters or inhibitory neurotransmitters, which allow the intercommunication between the microbiota members and the host. This is a very important picture which shows the various mechanisms through which the gut microbiome, various gut microbiota drive the nociception. Here you can see the basic cells, the enterochromaffin cells, which are the storehouse of serotonin, which I'll be discussing later when I talk about the serotonin metabolism. These serotonin secreting cells can activate modulate the serotonin sensitive primary afferent nerves. Also, catecholamine neurotransmitters like dopamine and norepinephrine, they can act through ADR2A and TRPC4, means transient receptor potential. These are signaling cascades through which, again, these agents can modify the visceral nociception. Also, dietary metabolites, short-chain fatty acids like butyrate, acetate, branched-chain fatty acids like isovalerate, they have multitude effects. For example, butyrate, they can tighten the intestinal barrier through the activation of hypoxia-inducible factors. They can also activate through the PPAR gamma mechanisms. They can also activate the olfactory receptors and PQ-type CAV channels. These are various receptors ultimately what happens is once these are activated, they control the visceral afferent mucosal visceral afferent circuit, thereby modulating visceral hypersensitivity. Also, dietary metabolites like tryptophan, which can be used by the bacteria to ferment products and form indole or kynurenine derivatives, these act through two different pathways. One is GPR35 and AHR. This is the aryl hydrocarbon pathways. Gut microbiota also plays an important role in maintaining the bile salt pool as well as the protease pools. Bile salts like chenodeoxycholic acid, they can act through the BAR1 receptors, and proteases modulate the intestinal barrier function by acting through the PAR, protease activated receptor 2 pathways. So a multitude of pathways. What ultimately happens is these gut microbiota try to control the visceral hypersensitivity not by a single channel but through multiple pathways. That's the bottom line. So going on to the animal studies, the preclinical data, this is mainly done by measuring the pain thresholds done in animals through fecal microbiota transplants. What they have shown when the animal rat models were colonized with stool microbiomes from IBS patients, then they had decreased pain thresholds. Also, the use of antibiotics in early life, like vancomycin in rats, they altered the gut microbiome and again leads to an increase in visceral hypersensitivity. And conversely, the administration of probiotics decreases the hypersensitivity. Interestingly, when adults were prescribed antibiotics, there was an improvement in visceral hypersensitivity, which might suggest that there are potential age-dependent effects of the microbiome. Also, varying with the menstrual cycle, estrous cycles in females, again the visceral pain responses were modulated, suggesting an interaction between the sex hormones, visceral pain, and the microbiome. So, building on insights from the animal models, human studies were done, exploring the various fecal microbiome changes. They have shown that in patients with IBS, specific taxa like Proteobacteria or Bifidobacterium can correlate the severity of the pain. Although the role of small intestinal microbiota in the pathophysiology of abdominal pain still is not clear. Here in this tabular column, we'll see data on the data about fiber and the diets which can alter the microbiome, gut microbiome. These actually preserve the barrier function by decreasing the lipopolysaccharide mediated mast cell activations. Fiber is of three types: soluble fibers or insoluble fibers or the mixed fibers. Psyllium is a soluble fiber. It has been, fiber has been assessed in IBS, but only few trials report the abdominal pain outcomes. In selected two RCTs on IBS patients, where they were able to show in one of the trials that the fiber did not have any benefit, in the other trial, at different endpoints, both psyllium and bran was found to be beneficial. These are very small studies with very few data. Coming to low food map diet, this is again data from a network meta-analysis by the CJ Black group. Low food map diet, that is the fermented oligodisaccharides, monosaccharides, and polyols. It was shown in the meta-analysis that it was superior to a sham diet, but was inferior to a British Dietary Association diet advice. And one of the trials where they evaluated the low food map diet in IBD patients in endoscopic remission, but with persistent gastrointestinal symptoms, the abdominal pain and severity with the low food map diet did not differ among the placebo group. Coming to rifaximin, it's a poorly absorbed gut antibiotics. It acts through multiple mechanisms. It inhibits the protein synthesis, and it can also modulate the gut microbiome. It's used in a dosage of 550 milligrams TID for around 2 weeks. Again, rifaximin was not shown to be beneficial over placebo. Adding on a few important areas where questions have come up all the time is one is regarding the probiotics. In a meta-analysis, it was shown that the combination of probiotics containing lactobacillus, bifidobacteria, and saccharomyces what was shown is that patients had improvement in abdominal pain, but what was the caveat of the studies is that there was a lot of heterogeneity in the data and a lot of selection publication bias in these trials. In general and overall, I should say probiotics, especially when used in combination, seem to be more effective, but what we don't know is which one to use, how long to use, what will be the dosage that we'll have to use in these patients. We still need more data on these. Another question that comes up is with regards to the fecal microbiota transplant. There are only 2 RCTs in around a small number of patients in both IBS and IBD. In one of the trials, a single FMT done with the nasojejunal tube in IBS patients with predominant bloating reported abdominal pain scores to be better. This is data from a much larger trial which shows the overall efficacy of FMT. This is done with 2 different doses, a 30 gram and a 60 gram dose from a single super donor, frozen FMT, which was delivered to the distal duodenum with an EGD. It was shown the abdominal pain scores had global improvement in the abdominal pain scores. But we still need more data, and FMT as an option for abdominal pain should not be used outside of a clinical trial. Going on to the other important paracrine molecule, histamine. Histamine, it functions as a paracrine signaling molecule that can activate nociceptors in the gastrointestinal tract. It is synthesized from L-histidine through the L-histidine decarboxylase. Histamine, once synthesized, has 2 predominant pathways. One is the diamine oxidase pathway and the N-methyltransferase pathway. Both these metabolites are important in visceral nociception. The histamine acts through 4 receptors, 4 G protein coupled receptors, that is H1, H2, H3, H4. H3 is not seen in humans. H1, H2, and H4. H2 is predominantly seen in gastric parietal cells, whereas H1 in smooth muscle connective tissue cells and H4 in immune cells. These G protein couples receptors signal intracellularly and modulate the various ion channels, again modulating either directly or indirectly the nociceptive neurons. And here you can see the preclinical data. Histamine release in humans, the various triggers for histamine release in animal models and humans have been studied. And here in this schema on the left side, you can see that when a combined food antigen was given to the mice, with triggers like acute self-limiting colitis or a psychological stress exposure, these caused an increased IgE release in the tissues, and following which mast cell degranulation happened and more histamine was produced. Again, on the right side, you can see that when a lot of complex carbohydrates, that is poorly absorbed carbohydrates, were given, these can again cause more of histamine release through the pathways. Especially in patients where specific microbes were found, like Klebsiella aerogenes, they were high. It was shown in the mice studies that these bacteria can produce 100 times more histamine than those lacking in the stool samples. Drugs targeting the histamine receptors, basically the H1 receptor antagonist, has not been clearly been well studied in GI diseases. Ketotifen is an H1 receptor antagonist which has been studied in IBS, just 1 RCT in a small number of patients. It was shown a significant improvement in abdominal pain with placebo. The other drug being Avastin, used at a dosage of 20 milligram once a day. Again, the rates of abdominal pain relief were higher, but it's not statistically significant. But the other molecule, which is disodium chromoglycate, is a mast cell stabilizer, which has been studied in 1 RCT. It was shown to have a significant improvement in abdominal pain in these patients. Going on to TRPV1 and visceral pain, the TRPV1 is a non-selective ligand-gated cation channel that is activated by a lot of stimuli like stretch, heat, low pH, or irritants like capsaicin or endogenous metabolites. TRPV1 in preclinical studies, what they have shown is basically when you ablate the TRPV1 projecting neurons in the colon, again, nociceptive responses were decreased. These TRPV1 expression is again can be modulated by sex hormones like estrogen. What is important is in patients with quiescent IBD with persistent GI symptoms, they were able to show that this TRPV1 expression was increased. One of the age-old molecules is peppermint oil. It's prepared from the herb Mentha peperta. It's been used for thousands of years in the management of stomach ailments. This molecule is used in a dosage of 2 capsules TID for pain-predominant IBS. It has shown that usage of peppermint oil in patients with IBS in one of the meta-analysis involving around 800 patients, there was significant improvement in pain. The other one is red pepper, the component being capsaicin, has also been tried, but which has shown to cause improvement in abdominal pain used for a continuous period of time. But the caveat of this study is a large number of patients dropped out due to pain exacerbations initially with this molecule. Going on to serotonin and visceral pain, as I already discussed, the enterochromaffin cells are the basic storehouses of serotonin. Serotonin plays an integral role in the initiation of intrinsic gut reflexes, regulating motility, secretion, and vasodilation. Serotonin acts through basically 2 receptors, the 5-HT3 and 5-HT4 receptors. The actions of the serotonin receptors are specifically terminated by the selective serotonin transporter. This is a receptor which is a peripheral target for the commonly used clinical drugs like SSRIs, SNRIs, and tricyclic antidepressants. Basically, the enterochromaffin cells are electrically excitable cells. These are found in the mucosa. They display an axon-like basal process. The enterochromaffin cells have these axon-like basal process, and these intercommunicate with the other extrinsic and the intrinsic afferent neurons, and they're called as neuropods. The enterochromaffin cells basically function as a luminal sensory transducers. They are activated by a variety of stimuli like bacterial metabolites or inflammatory cytokines, etc. And these relay the signals through intercommunications through these neuropods. This is the animal data from based on the studies from serotonin, where you can see in the pictures that there is selective sex differences in the activation of the basal afferent activity, which is seen in females. More elevated basal afferent activity was seen in female mice than in males, suggesting that there are sex differences. The activation of the mucosal afferent enterochromaffin cell circuit. Serotonin, basically clinically what we use are serotonin antagonists like 5-HT3 antagonist and 5-HT4 agonist, which act through the serotonin receptors. The efficacy of serotonin 5-HT3 receptor antagonist, that is the prototype molecule being allosetron and ramosetron, which is used in IBS Both these molecules were shown in multiple IBS-D trials that they have been shown to be superior to placebo, but allosetron has been associated with a significant side effect of ischemic colitis. Ondansetron has also been studied, but was not found to be beneficial. And with regards to the various SSRIs, tricyclic antidepressants, and SNRIs, SSRIs were not shown to be beneficial for when you treat for abdominal pain, whereas tricyclic antidepressants were shown to be more efficacious to placebo. SNRI, again, when there is a component of anxiety involved in your treatment of patients, they were found to be beneficial in the treatment of abdominal pain. For want of time, I'll rush through these slides. Cannabinoids, the basic molecule for cannabinoid is they act through the CB1 and CB2 receptor agonists. Olorinumab is a new molecule which acts through the CB1 receptor. It has been shown in a dose ranging study in both IBS and IBD that at a dosage of around 50 to 100 milligrams, it was found to be clinically beneficial. Going on to GABA. GABA is an endogenous molecule which is synthesized from glutamate through the glutamate decarboxylase pathway. These act through the GABA A and B receptors, which again modulate the pain. On the left side, this was a trial done in IBS patients. On the right, you can see the trial done in functional dyspepsia patients, in which both pregabalin used as a dosage of 75 milligrams once a day were shown to significantly improve abdominal pain scores for the FDA recommended endpoints. So to summarize, despite the potential for various evidence-based treatment, there still remains a need for the development of novel therapeutics. What future holds for us is we have to identify the various microbial versus host sources of peripheral targets. We have to identify each of these pathways, what is the relative contribution of each of these central as well as the peripheral pathways, as well as the mechanisms which might be similar or differing mechanisms involved in the treatment of chronic visceral pain disorders. Thank you.
To bring all the moleculars which were disregarded into practice. It is really exciting one. The only thing we have reminded of what we call as old wine in the new bottle. That is, peppermint oil was disregarded and all the randomized control trials on peppermint oil were disregarded once upon a time, and now you are again getting up. Anyhow, how many molecules are going to find the clinical application and all that are open to questions. Any floor opinion, please?
I think infantile colic was the youngest thing. I think a lot of studies were done because an infant at 3 months crying for nearly an hour. There, the only study which proved was that you said no lactobacillus reuteri, but nothing much. The frequency of pain and the intensity of pain was less. The baby did cry. So they have to give for 28 days. By that time, the pain also will go. So I think that was the end result. We didn't get much in that. So peppermint oil in children is not helping us much. FODMAPs is helping us. But I think lactose also was one of the things. But you were talking about more the therapeutics, you know.
What
so
they've shown in probiotics is now the combination of probiotics have a role.
Yes, I think more the combination 8 and thing which seems to be working. So, but still there's no end at the end. Finally, I think we will be talking about opioids will be the ones which we'll all hold.
This is basically like all these things are upcoming, ma'am. We still need more data. Everything is now like test and treat strategy you have to follow. You have to try, based on the patient profile, you choose the drugs and then decide on what needs to be done.
Mebevirin, where do we get that? Where do we put that? Mebevirin?
It has been shown, ma'am, these antispasmodics. Data on antispasmodics is there for IBS. For specifically, RCTs have not been done for the evaluating the component of abdominal pain, global symptoms. And currently, they are not recommended.
Drotaverin also. We
Yes.
have found amitriptyline working for our children with functional abdominal pain, especially those with
Data was also again shown for amitriptyline in functional dyspepsia was shown improvement, ma'am.
Yes. So we are using that for 1 month. It's helping. 12 weeks.
Thank you, Dr. Raghavendra, for
Thank
the
you, sir. Thank you.
thought-provoking lecture. Next, I will call upon Dr. Anand Murugesan, Senior Consultant Anesthesiology, Apollo Hospital, to talk on pain intervention in chronic abdominal pain, a panoramic view.
Good evening, seniors and colleagues. It's always a challenge to be the last speaker in the meeting because like Pirama has already given me the heads up, like it's not 30 minutes of your talk, it's now only 15. So I have to skip through a lot of slides, but I really thank my previous speaker, Dr. Raghavendra, who has actually covered a part of it, the anatomy and the physiology bit. So I think that may help me. So I'm Dr. Anand Murugesan. I'm a consultant anesthesiologist and I do interventional pain practice in Apollo Hospitals, Chennai. So it's really thrilled to be in front of the gastroenterology forum as a pain specialist. Thanks for the Indian Society of Gastroenterology Tamil Nadu chapter for this. And with that, I'll start my talk and I hope I do justice to my topic. This is skipping through, right? This is skipping. Okay. The topic is like the pain intervention. So like, let me just stick to the pain intervention part of it. The pharmacological bit was already covered. So I have no conflict of interest, no disclosures, no funding either. And this is the hospitals I cover every day. I go to 3 units in Apollo Hospital. I express my deep gratitude to my institution, Apollo Hospitals. Like, because of them, I'm here. So I do cover Apollo Proton Cancer Center, Apollo Main Hospital, and Thenampet Cancer Institute as an interventional pain specialist. So we are going to just discuss few of this over the next 15 minutes. As I said, like Dr. Raghavendra has rightly mentioned about the definition of the pain, I would like to just add upon this definition. So the initial definition proposed by the Indian International Association of Study of Pain is an unpleasant physical and emotional inexperience due to a potential tissue damage, which actually has been revised now. There need not be any potential tissue damage. Even if it resembles a damage to the tissues inside, still it can be considered as a pain. So why it is revised? Because the pain has been taken so seriously these days, because it has been considered as a human right. And pain is the fifth vital sign, like our blood pressure, heart rate, and oxygen saturation. So because of the emphasis on treating the pain, evaluating the pain, the WHO has revised the definition as saying, even if it resembles the potential tissue damage, still it should be considered as a pain, and we should treat it vigorously. So why we should know about the definition of the pain? Because each pain has got its own pathway, own anatomical configuration, anatomical structure. And once you understand the pathophysiology of the pain, the definition of the pain, the treatment varies. So it's not the treatment or the pain intervention for all types of pain. So there comes the understanding of the types of pain. So the somatic pain is more sharp and localized, like an incision pain or a bone pain or a muscle pain. So it is like more localized, and it's from the somatic system of the body. The visceral pain is what Dr. Raghavendra rightly described. It comes from the viscera, either due to the stretching or the compression or the infiltration of the viscera of the abdominal visceral organs. So that causes a sort of squeezing, deep, colicky type of pain. So it has got its own anatomical configuration, as he rightly described about the pathways, pain pathways. So the neuropathic pain is the one which is actually due to a definitive damage to the nerve itself. We know the pain is mediated through the nerve, but the neuropathic pain is the one which is due to the damage to the nerve itself, which can happen in few of the abdominal pain conditions, which I'll be discussing it soon. Sympathetic pain is an involvement of the sympathetic nervous system in a chronic pain. Any pain which is lasting more than 3 months, we call it as a chronic pain. And subsequently, it starts with a low intensity, and the intensity of the pain increases with involvement of the sympathetic systems like the allodynia and hyperalgesia, as rightly described by Dr. Raghavendra. That is because of the involvement of the sympathetic nervous system, eventually as the pain continues to grow without you deal with it. So the dorsal root ganglion is one of the target, because that's a relay center for the sensory nerves where you can target it. And moreover, for the visceral pain, another important target is the ganglion. So why we have so much emphasis on the ganglion is like the GVA. It's called it as general visceral afferent, which is actually a sympathetic sensory afferent, which takes its pain from the viscera, abdominal viscera, and it goes via this ganglion, and second relay center is the dorsal root ganglion. So the dorsal root ganglion is the ultimate relay center, which is close to the spinal cord. But what happens, like each viscera is supplied by the contribution from more than 4 or 5 thoracic segments. Say, like for example, if it is a pancreas or stomach or liver, like the sympathetic system starts from T5 to T12. So if there is a pain coming from pancreas, for example, so it's very difficult to deal with 6 or 7 dorsal root ganglions for an interventional pain specialist. So rather it becomes so easy to just target this one ganglion, because all these 5 or 6 efferent nerves from the thoracic segments relay here as a preganglionic fibers. And from here it goes as a postganglionic fibers and supplies the viscera. The GVA is the most important, the nervous system. It's an afferent sensory system from the viscera goes via this ganglion and it relays in the DRG. So as a pain specialist, I would be more interested to deal with this structure to break the pain by intervention. So this is a slide which comprises what are all the area of my interest in chronic visceral pain in abdomen. So one is the celiac ganglion, which is right here at the L1 in front of the aorta, where it receives fibers from the greater, less, and least splanchnic nerves from T6 to T12. Retrocrurally enters the diaphragm and it makes a flexus here. The celiac flexus is actually a group of a paired celiac ganglion, superior mesenteric, and aortorenal. The 6 ganglions put together as form a sheet of a nervous system called celiac ganglion, which actually takes the sensory visceral inputs from your upper abdominal structures, right from the esophagus, stomach, small intestine, and the ascending colon, and up to proximal 1/3 of the transverse colon. And next ganglion of my interest is your hypogastric flexus, which is right here at the level of S1 or T12, where it takes the inputs from the lower abdominal structures, right from the transverse, the distal transverse colon, descending colon, sigmoid, rectum, and anus. And apart from that, we have the uterus and the pelvic organs also gives their sensory inputs to the superior hypogastric flexus. So these two structures, this celiac flexus and hypogastric flexus, are the two which covers the entire abdominal sensory inputs. If you can deal with these two, depending on the pathology, we can take care of the visceral pain by intervention. So this is actually a WHO ladder of the pain. Initially, the WHO said we have got only 3 ladders. To start with a non-steroidal anti-inflammatory and an adjuvant analgesics, and if pain slightly more, climb up the ladder, start with the weaker opioids. Then if it's still there, go up the ladder to step 3, where you can give us strong opioids. But the revised WHO guideline says we have got ladder 4, which is actually an interventional pain. It's not just the ladder 4 you have to climb from 3, it is bidirectional. So now you are going to give interventional pain option to a patient even in step 1. Even if the patient comes with a mild to moderate pain, there is a significant advantage of doing this intervention early in a patient. Thereby, you can avoid the pharmacological related side effects to the patient and also to offer a better quality of life. So why intervention? As I said, it's more targeted. Like you see, in pharmacology, like we give medications, it may have an undesirable side effect. Over here, it's more targeted. We are targeting the ganglion and you are breaking the pain cycle. So the medications what you give can be less, so you are not yielding the patient to have the side effects due to the medication. And obviously, it is very evidence-based, having a superior analgesia over your pharmacological methods. So when to start? Earlier is the best. As I said, it's bidirectional WHO pain ladder, especially in cancer. So in non-cancer, maybe like we should go for a pharmacological method. In cancer, we have a zero tolerance pain policy where it has to be given as a first choice to the patient for oncological abdominal pain. So earlier is the best. So these are all the equipments I generally use. We need to have an ultrasound and the radio frequency machine. So that's a radio frequency ablator we'll be using for ablating the ganglion. And we use a fluoroscopy for most of the intervention. And these days, the ultrasound is gaining more popularity in dealing with the same blocks, which was done traditionally in fluoroscopy. So that is going to help us to save us from the radiation-induced injuries. So this is a neuromodulation device come from Medtronic, where it's an intrathecal implanting device that helps in the last stage when none of this intervention helps. We have to place the catheter in the intrathecal space and give morphine and bury it in the subcutaneous plane and give the continuous morphine delivery, which is really going to help the patient in the last stages of the cancer. So based all these abdominal blocks, all the pain abdominal interventions are better to be done in a good in-hospital settings with good backups, because as the sympathetic nervous system is involved, unlike the somatic blocks, we may have a significant hypotension, bradycardia, arrhythmias following this procedure. So it has to be done in a place where you have a good infrastructure and good anesthesiology backup and good ICU backup. So these are all the 4 basic interventions we do in chronic abdominal pain. One is the sympathetic block. We deal with the ganglion, as I rightly said, for the visceral pain. The second is the somatic pain, where the pain comes from the parietal abdomen and also from the abdominal wall itself. So they comes under the somatic type of pain, where deal with your nerves, somatic nerves. And these neuraxial blocks we generally give for a chronic pain patients like the continuous epidural analgesia who has got the life expectancy of 4 to 6 weeks, like where there is nothing much to offer, place in a continuous epidural catheter, tunnel it in the subcutaneous plane, and then give the local anesthetic with opioid into it, so where you can give some piece of life to them in their last lap of life. And neuromodulation is the recent advances now, not just for the oncological abdominal pain, even for the non-oncological pain, coming up in a big way, so which I'll be touching it upon in few of the slides. So in sympathetic blocks, we have, as I mentioned, like celiac, hypogastric, and ganglion impart. The ganglion impart is more for the perineal pain, so which is out of the focus in this talk. But of course, celiac flexus for upper GI and the superior hypogastric flex for the lower GI and the pelvic pain. So the celiac flexus is a sympathetic flexus and takes inputs from the upper GI, upper abdominal structures, as I said, from esophagus, stomach, pancreas, liver, and the small intestine, and bit of colon as well. So it can be dealt with both a fluoroscopy and ultrasound. As I said, the ultrasound forum is coming up in a big way, and I'll be showing it in one of my slides here. So it is one of the best block. So it can be done by one of these three techniques. We have a retrocrural, anterocrural, and transcrural transaortic technique. So traditionally it has been retrocrural Capis technique, like where the needle is placed in the retroperitoneally behind the diaphragm and give the volume driven block goes and blocks the celiac flexus. The anterocrural is more of an ultrasound. Transabdominally do an ultrasonography, see the structures, and then go and then give the block. This is for maybe like ideally reserved for the patient whom we cannot mobilize them to the operation theater. Like they'll be like in sort of terminally ill stage, like with, but still screams with pain, like because this traditionally done retrocrural method is like you have to place them in the prone position and then shift them to the operation theater. But this just anterocrural can be done on the bedside with an ultrasound. So, and the transaortic is what I do, I prefer, because this has got a better evidence and better superior pain relief over these two, because I go through and through aorta where the celiac flexus is exactly located over the aorta at the L1 level. So this is the technique, retrocrural technique, as I said. So first I make it as a oblique. This is a needle entry point between the transverse process of L1 and the waist of the vertebrae. So once needle is placed here, I make it lateral. The lateral tells like how deep I should go, and the needle should be restricted to the corresponding to the anterior border of the L1 vertebrae. Inject the contrast, check for the linear spread, and then inject. This is a retrocrural approach. This is not a transaortic approach. This is a traditionally done called Capis approach. So next is the transcrural. What I am doing is like come from posteriorly. After you reach the anterior border of the vertebral body, the aorta is just hugging the L1 vertebrae. As you pass the anterior border, you will get the jet of blood. Just go through and through till the blood stops. The celiac flexus is right over, sitting on the aorta, and this will be more precise, and you can give only the less medications, less alcohol, so thereby you can avoid the complications due to alcohol, and more than anything, it gives a superior pain relief when compared to the traditionally done celiac plexus block retrocrurally. So this is a patient I did for pancreatic carcinoma, CA pancreas with visceral pain. So I have been doing this transaortic method of celiac flexus. So the needle is actually placed at the L1 level here. The patient is placed, put prone, and you can see the ipsilateral left-sided oblique view. The needle placement is at the junction between the transverse process and the waist of the L1 vertebral body, and I have to make it lateral view in the lateral to know the depth. In the left side of the screen you can see already I have gone deep and my needle is exactly at the anterior border of the L1 vertebral body. Now, if I further advance, I am going to puncture the aorta, where the aorta will be hugging the vertebral body linearly. And I am going to pass through and through aorta, where the celiac plexus will be exactly sitting on the aorta. Can you show here? You can see the blood coming out here. So now you can see the blood coming, that is your aorta. So as I said, this is a transaortic technique. So I have to go past the aorta through and through till the blood stops. Now the blood stopped. So I am injecting contrast here. So the contrast is going to tell I am in the aorta or I have gone past the aorta. Fluoro. You can see the nice contrast spread. So I am going to give 80% of alcohol here, 20 mils of alcohol that is going to spread across. So that's the transaortic method of doing the celiac plexus, which I follow. So next is the anterior approach. Anterior approach is generally done using ultrasound. Obviously we can't use the fluoroscopy for anterior approach, and we'll go through the left lobe of liver and at times the stomach as well. So the area of interest here is like get the aorta in the view at the L1, and you get the celiac trunk arising from the aorta that bifurcates into your common hepatic and your splenic artery. So this is your scout flame, and try to get, it's called ram horn sign. So it's like it's a horn of the ram. So get this in the transverse, this is a transverse scanning, get this view, and the needle can come exactly at the junction between this common hepatic and the splenic artery junction, and you deposit. The drug will spread here, and then you get the celiac plexus blocked. And you can do a linear scanning, and this is another method, same transverse scanning, you could make it a linear scanning and get the same celiac trunk here, and the second, which is just below the celiac trunk, is a superior mesenteric artery, and this is your renal artery. So these three are the trio. So you need to come from capsular to caudal, and the junction between the main trunk of the aorta and the celiac trunk, this is the pad of fat. This is the celiac pad of fat here, where you can just deposit here, you get the sheet of celiac plexus here. This is how an anterior approach of celiac plexus block done using ultrasound. So what is the advantage of anterior approach? Because like there are reports of the paraplegia reported 1 in a lakh in a patient with the prone position in a retrocrural because of the involvement of this alcohol dissipating back and enter into the neural element causing paraplegia. So in ultrasound, you see the structure there, you are anterior, you are not anywhere close to the spinal cord, and thereby you can avoid the risk of paraplegia by the traditionally done celiac plexus block. And of course, in a large tumors and obese individuals, it's really tricky to do because like any deeper structures, ultrasound is a little challenge. Little superficial, like the resolution is better. So that's why a patient with increased abdominal fat and the large tumor obscuring the celiac trunk, obviously it will be a bit challenge. In fact, it will be very difficult to do it in the anterior approach. So this is a splanchnic nerve. The splanchnic nerve is actually nothing but the celiac plexus itself, because the celiac plexus is formed by the splanchnic nerve. In case like if you are not because the celiac plexus needs a little learning curve, and it is little unsafe at times. I was talking about the paraplegia, all those things. Splanchnic nerve is relatively a simple block for the beginners, and it is very safe. And like before, you don't need to go past the aorta. Like same, you choose the T12, T11 vertebral body, and enter the junction between your rib and the waist of the T11 vertebral body. And the needle tip should be just at the junction between your anterior 1/3 and the posterior 2/3 of the vertebral body of T11. So why it is called safe? Like you don't need to give alcohol here. You can do a radiofrequency ablation. The advantage of radiofrequency ablation, it's a thermal ablation, like where you don't need to worry about the spillage of your alcohol into the posterior neural elements causing paraplegia. Here the heat energy is going to ablate this splanchnic nerves, so there won't be any seepage of your chemical neurolytic agents backwards and causing damage. So it's more targeted, more focused. It's only the heat that is ablating it, relatively very safe. So I'm just skipping through. So this is a hypogastric flexus, again said for the lower abdominal structures, from the transverse colon, distal, descending colon, rectosigmoid until anus, like you get the general visceral afferent fibers converging at the L5 and S1 junction, exactly at the promontory. That's the target where the needle comes from posterior till here, and it is again a sheet of the nerves which spread like a sheet, and then you can inject the alcohol there, 80% alcohol there. Again, it is a transdiscal approach. You have to come from the L5S1 disc through and through disc, like over there, it's through and through aorta, here over through and through L5S1 disc, and enters just up in front of the L5S1 disc, and then deposit the alcohol, like where the hypogastric flexus gets blocked. So this is the through and through technique and the linear spread. So the contrast is very important because this is the place where the aorta gets bifurcated into the iliac veins. So again, in the needle, you should see you are getting the blood. You are getting a blood as an aspirant. And neither the contrast should go into the disc space where it can cause discitis. So the contrast conformation is very important in this transdiscal approach of superior hypogastric flexus. So this is a procedural video I'm skipping through for want of time. So ganglion impar, like it's for the perineal pain. It's for the proctitis, chronic proctitis, and vaginismus, and all the perineal related pains. It's again a terminal sympathetic ganglion. You do the ablation for the perineal, the pathologies involving the perineal structures. So somatic blocks. So we discussed about the visceral pain and the sympathetic blocks. So what is somatic? See, the parietal pain is like more somatic, like the pain comes from the muscle, the pain comes from the skin, the pain comes from one of the nerves there entrapped. So we have to consider giving the somatic blocks for that could be the reason for the abdominal pain. So this is one which is generally ignored, and it's a real gray area. Like I do get a lot of reference from gastroenterologist about the vague abdominal pain, like all the scans, everything is normal with just some previous abdominal scars. But the character of the pain is like more neuropathic. But all imaging wise, everything will be normal. So like it will be like more scarring that has happened in the previous abdominal surgeries at the rectus level. Like at the linea alba, the anterior cutaneous nerve comes out from intra-abdominal to the superficial structure. It gets entrapped there due to the fibrosis, and they will get just neuropathic pain. We call it as an anterior cutaneous pain syndrome, where you have to just go between the rectus sheath and the rectus muscle, place a catheter, and then just give a continuous infusion for about a day. That is going to break the pain cycle, and that is going to be an effective treatment for the anterior cutaneous pain syndrome. And the ilioinguinal iliohypogastric is a nerve entrapment syndrome due to your herniorrhaphies, due to the mesh entrapment of the ilioinguinal hypogastric nerves, where the patient presents with the groin pain along the distribution of the ilioinguinal and iliohypogastric nerves. Like we can do a very nice ultrasound guided ilioinguinal iliohypogastric blocks here, and we can do a pulsed radiofrequency ablation as well for intent to give a long-term pain relief. So the neuraxial blocks, as I said, like reserved for a terminally ill patients, like we can just place the catheter in the epidural space and give a continuous infusion, and we can remove it as and when. You can repeat the procedure as well. So this is a neuromodulation device. A catheter is placed in the intrathecal space and give a continuous morphine, and the reservoir is placed in the subcutaneous plane, and the continuous delivery is advised. So the advantage of giving an intrathecal morphine is like, it is like 1:300 ratio of the morphine. Like 300 milligram of oral morphine is just 1 milligram. So the dosage given is too less, and thereby we are not giving them the side effects of the opioids by administering in the intrathecal space. So this is a recent advance. With this, I just would like to complete. See, there are some areas, entities which are coming up called the complex regional pain syndrome 2, where there is a demonstrable injury to the nerve, either in terms of the surgical, mostly it will be an iatrogenic. So the patient starts with pain initially with a small pain, but disproportionately the pain keep on increasing. That happens, as we discussed, in inguinodynia and in chronic testicular pain, where like we can consider doing a dorsal root ganglion stimulation And this is what recently I did. This is India's first dorsal root ganglion stimulation for a chronic testicular pain, which I have done 3 weeks back in Apollo Hospital, Greaves Road, for a Oman patient who undergone a testicular seminoma surgery, for which the high inguinal orchidectomy has been done, and post-surgery patient developed an inguinodynia and genitofemoral neuralgia. So not responded to any conventional line of treatment. So I placed this electrode at the L1 dorsal root ganglion, trialing, and then 2 weeks patient responded well, and it was implanted, and 4 weeks post the implantation the patient is doing very well. So again, the spinal cord stimulation works with the same mechanism of gate control theory. You stimulate the dorsal column and your pain signals gets blocked. So this is one last slide I would like to complete. My apologies to everyone, because this is one such very interesting lady who came to me with an intractable pain. The patient undergone a mesh hernioplasty about a year back, and the mesh got infected, and she has to come for surgery twice, and twice the patient was re-explored, and the third surgery was about the mesh was removed. So after that, the pain was disproportionately very high. I would like to show. You get the sound? It is a ripping pain. This is the patient was not able to just get up from the bed. She's just 35 years old.
No complexity, man. No complexity.
This is the Budapest criteria of the complex regional pain syndrome stage 4. Like in high severity of the CRPS, patient may throw convulsions and they may have clonus and sort of severe dystonia. So this is the post dorsal root ganglion pulse radio frequency ablation. The next day the lady is walking freely. This is again, as Dr. Raghavendra mentioned, like dorsal root ganglion is the root value of the somatic nerves. In fact, even your sympathetic nerves. So this particular lady, I did the T8, T9, T11 thoracic, thoracoabdominal nerves at the DRG level. This is the needle. This is placed anteriorly at the 8, 9, 10, 11 DRG, confirmed in lateral, and we did the pulse radio frequency ablation, and she's doing really well. So this is the literature, a lot of literatures I viewed. So in summary, the clinical, as Dr. K.R. Pisar rightly mentioned, the clinical examination is the clue. I always spend half an hour with the patient, try to understand what is the type of the pain. Most of the occasion, even without imaging, I'll come to know whether it is a visceral pain or a sympathetic pain or a somatic pain. So the patient clearly will tell the way he describes the pain, we'll come to know exactly what type of pain it is, so we can deal accordingly. And the pain generator is the pivotal we will know once you examine the patient properly. And early intervention is the key, as rightly mentioned. And the neuromodulation is coming up in a big way in future, which is going to help a lot of patients. Especially the gray areas are going to be covered very soon. And thanks for the opportunity.
Thank you very much for your nice updating on your complex intervention procedures. Thank you very much, sir. The few interaction from the audience.
It is 15 centimeters, 22 gauge. 22 gauge, 15 centimeters length needle. We have to inject air. Because you inject alcohol, there should not be any spillage of alcohol as you withdraw the needle. So once the alcohol is deposited, I take one 10 ml syringe, I try to push air. So once I push air, the drug will be already delivered, sir, and then I'll just push it out. As I inject the air, I withdraw the needle. No, because we are just, because there is no alcohol there around the needle at the skin level. If the alcohol spillover happens at the skin level, there can be an excoriation. But as you inject the air, most of the alcohol is dissipated viscerally, intraabdominally. So there won't be any alcohol spillage at the skin level to cause any excoriations.
In case the risk of introducing alcohol into the aorta.
Yeah, it is there. That is why it is very, very risky. Like we have to confirm it with the fluoroscopy, and the contrast has to go linearly. It should not dissipate. And then before you give, aspirate it and give. But if you are in aorta, if you aspirate, you can't just miss. The blood will come because aorta will produce a jet. As I inject, I give, because that I will not give directly. The needle is not, the syringe is not placed exactly over the needle. You can see in that video, I placed one 10 centimeter extension. So that 10 centimeter extension will anchor the needle. It will neither push the needle inside or out. So that will give a steadiness of the needle.
Okay, sir. Thank you very much, sir.
Thank you.
As a token of appreciation, Dr. Ratnaswamy will honor our guest speaker.
Oh, thank you, sir.
Thank you, sir. Thank you, the chairpersons, for conducting the proceedings, and I thank all the members who have participated for today's CME, all the speakers, and also the hotel staff and our main support from Sun Pharma as well. So I invite you all for the dinner, please. Thank you.